All right, guys, so we're going to move into chapter 4 and we're going to start talking about the actual administration of drugs. So be mindful of the things that you've learned in the previous 3 chapters, especially those that relate to a patient's non-rights of drug administration. Okay, so we want to make sure to always keep those in the forefront of our mind when we are administering medication or preparing to administer medication. I want you to also remember that we should always double check and triple check our orders prior to administration, and not only our orders. Remember, we want to be reading those drug labels at least 3 times before we actually, or before it actually reaches the body of that patient in whatever route it's been ordered. Okay, so just remember the non-rights, and again, triple check those orders, triple check those drugs that you're actually giving, and excuse me, just be mindful of patient safety at all times. So as we move forward, we'll dive into that a little bit more. Just don't forget what you've already learned. Okay, so we're going to start talking about units of measure when referring to drug dosages. So in order to be able to read and write those drug orders and prescriptions appropriately, we need to know how they should be written, because that is extremely important in order to minimize the chance that we may misread a drug order. Okay, and we all know that if there's ever a question, of course, verify that, but there are instances when we may just sadly to say, get in a hurry and misread a drug order. So we want to prevent that. So we use very specific units of measure. There are specific abbreviations that you can and cannot use. Okay, so we will talk about those and be mindful of those. Of course, the metric system is what we use. We use grams. Of course, I don't see that one a whole lot. Most of the time it's milligrams and micrograms that I see. Milliliters, of course, and then we have cubic centimeters, but we don't ever want to use cc when we're referring or doing dosage and calculations. We always want to use those the abbreviation milliliters. So don't ever use cc as a substitute for mLs, okay? And don't ever use mg instead of mcg for micrograms, okay? Don't ever confuse the two. So when we're talking about dosages, most of them are measured in grams, milligrams, and micrograms just because they're measured by weight. Okay, again, for height and things, we have millimeters, centimeters, and inches. And then, of course, we have units. Now, international units is what it's typically referred to as, and you can never abbreviate that. Never abbreviate units at all whatsoever. Especially insulin. Insulin is dosed in units, so you should always write units instead of U. Never use that, okay? MEQs is sometimes for potassium chloride. So that would be your mill equivalents. That's another measure that you might see often, MEQs. So just be familiar with a lot of those. GTTS, of course, is your drops. We'll use those when we talk about calculating IV rates, okay? Now, when we talk about our units of measure, again, don't forget what you've learned, okay? We always use our decimals for any dose that is, for example, 3.5 mLs or 3.5 milligrams. However, we always want to be mindful of also of the fact that we do not leave off any zeros, the leading zeros. Okay, so again, just to revisit some of those, if you are uncomfortable with conversions, your milliliters and teaspoons and micrograms to milligrams, make sure that you're looking back over those conversion charts so that you don't miss those math problems, because you are going to have math problems from quizzes to every single test from here on out in pharmacology. So make sure that you're aware of those. Okay, so of course, if you have any questions, you can always verify the dose, verify the order. Okay, you can calculate it yourself. That's why we drill dimensional analysis into you so many times, because it's important that you are calculating those, especially when you are out on your own, until you kind of familiarize yourself with normal doses and things like that. Okay, there are other things like grains and pounds, something like that, drains, or I'm sorry, drams, which was used in like apothecary systems, but you rarely ever see those. So be familiar with the ones that are on this slide and how to convert each of those. Oftentimes in nursing, you will hear people refer to children as small adults. That has been prevalent for some time. However, that is not true. Please do not go into your career thinking that children are just small adult patients. It's very different in how we dose our infant and children, and also our neonatal patients. Okay, most often it's going to be based on weight, and especially kilograms. We rarely ever use pounds when we're dosing children. So if you don't know that conversion for calculation purposes, make sure that you revisit that. So 2.2 pounds equals 1 kilogram. I can promise you, you will see some testing questions or quiz questions when you're doing math related to kilograms. Now we also do safety dosing for children. So we always calculate a safe dose for infants and children. It's extremely important to understand that the reason for those safe dosing practices are because children are very different and they tend to grow. And as they grow, their dosages have to be adjusted. Different drugs have different effects. And you have to also, again, take into account that some children have immature organs. Your neonatal patients especially, and your young infants, they may not have those mature organs to produce the same effect of a drug that maybe your normal 1 or 2 year old. Okay, so just kind of the difference there, or even your 5 to 6 year old, they're different, so you have to treat them differently. So keep that in mind when we're talking about drug dosages for children and how we calculate them. Most pediatric orders are most often written as, say, 10 milligrams per kilogram per dose. And you guys will see some of these math problems, so make sure that you understand how to actually calculate those. Okay, so in order for you to be able to make sure that you're giving a safe dose, you're going to use that 10 milligram per kilogram per dose in order to find out if you're giving them an appropriate dose. Now, other times, if it's a medication that they get often, or for instance, antibiotics or something like that, where they're getting them every 6 hours or twice a day, you're going to see them written as 5 milligrams per kilogram per day. So you're going to solve that mathematical equation just the same as the 10 milligram per kilogram per dose. Just know how to convert that pounds to kilograms both ways. And then oftentimes this is how you're going to see those orders written. You're not just going to say, your order is not going to just say give 10 milligrams every 6 hours. You're going to see it written 10 milligrams per kilogram per dose. So one of the reasons we have our pediatric orders written this way is because, again, with those immature organs, we all know that there's a small safety margin. That's why we call them the safe dose calculations. Okay, a lot of medications, remember, are very toxic to children. Gentamicin especially can be ototoxic. It can seriously affect their hearing, and so it's one that's given very often in the pediatric world. And so we have to be very careful about how we dose it. And again, we're monitoring those peak and trough levels. So this allows us to do that. So there are two methods that we use for pediatrics and infants, and we'll talk about those. So the first one is Clark's rule, and then the other is body surface area. I rarely ever see body surface area used, but I did often see Clark's rule, so we'll talk about both of those. So Clark's rule is simply using ratio and proportion based on their weight. Body surface area is a method using the total area of a patient, the total body area and tissue. And so they're using height and weight. This is a little different, but it's from when we talked about the absorption area in the gut. This is a little bit different when we're talking about body surface area. So let's look at those two methods. I'll give you an example of each of them in the calculations, and then just be sure to review those before your testing time. Okay, so let's dive into Clark's rule. Clark's rule is widely used to determine a child's dosage. Typically, this is for children ages 2 to 17. So it's calculated the same way that you would use ratio and proportion for an adult dose. The only difference is you'll see in this one, there is, you multiply in the calculation by the adult dose. So typically, adult dosages are based on 150-pound adult. So they're going by an average adult weight of 150 pounds. Okay. So typically, again, you're not going to see it written this way in your orders for medications. You're going to see that 10 milligrams per kilogram per day, etc. But this is just a quick way for nurses or pediatric nurses especially to just make sure that they're actually giving a pediatric dose rather than an adult dose of medication. Now, we all know as nurses, or as you learned in the last chapters, pediatric patients are different and so are the geriatric patients. So when we're calculating, we have to also remember the dosages are going to be less because again, you have those immature organs, or you have some type of, maybe another condition going on. And so we want to make sure that we're giving these children safe dosages. Okay. So I highly suggest calculating those, even if you have been in practice for 3, 4, 5 years. Just always double check your dosages because there are many times that I've seen mistakes myself. I worked in a pediatric and NICU units and I've seen them. So always make sure that you're calculating those. So you'll see here, I've given you an example calculating a dose of amoxicillin for a child. So they've given you the child's weight in kilograms and they've given you the child's height. So really all we need is the kilograms. And so when you guys are working math problems, remember there may be a time when you have some extra information in there. So just kind of train your mind to pick out what you really need. And so that again comes into play in knowing those mathematical equations and how to calculate them. So for Clark's rule, you're going to calculate the child's dose, you see that you're going to take the weight of the child in pounds, which we didn't know what it was, so we had to calculate that. And that's where you get into your 2.2 conversion into kilograms. And so that led us to 39.6 pounds. So 39.6 pounds divided by that average adult weight of 150 pounds times whatever the adult dose has been calculated to be. So you'll see at the bottom, it was 39.6 divided by 150 pounds times that average adult dose of 250 milligrams, which gave them 66 milligrams, which that sounds about normal for me, just recalling some pediatric dosages. So that's how you're going to calculate those children's dosages using Clark's rule. So just be mindful of those and know that it may give you kilograms and you're going to have to convert that back into pounds in order to work this problem. Okay, so be very familiar with that. You will see those mathematical problems using Clark's rule. This is your body surface area calculation. You can see the nomogram that I've also placed on here. So if you have the child's height and weight, then you can intersect those to get your body surface area, which you'll see the red arrow pointing to that body surface area. So again, that's what you would use in your calculation that you can see at the top. So you can see how it's easier and quicker to use Clark's rule, even though most people say that the BSA is certainly a more accurate way of dosing children than using Clark's rule. I will not test you on a body surface area, but I just wanted you to know that there are other ways to calculate drugs for pediatric patients. And this is the formula that you would use. And if you were to see a nomogram, you would know or be able to recognize what that is used for. So enteral administration of drugs simply refers to the administration of medications directly into the GI tract. This is oral through some type of gastric tube, either NG or PEG tube, or rectally. We don't typically think about inserting medications through the anus for absorption, but our GI tract starts with the mouth and ends with the anus, so from one orifice to the other. Now, don't forget, I have talked to you in the past about this. Previously, suppositories that have, in fact, been given to patients by mouth, which is absolutely not their intent or even remotely the correct route of administration. So remember, check your orders, make sure it's going into the orifice in which it is intended. Now, one advantage to rectal administration is it bypasses the portal circulation, therefore increasing the availability of the drug. Again, we always want to be mindful of our safety guidelines and wearing our PPE when administering medications. So one thing I'd like to mention when we talk about rectal drugs is, of course, the use of your gloves naturally and lubrication. Anytime that you're giving a suppository, always make sure that you're using a lubricant. Most of them are just, the suppositories are just a little bullet-like suppository, and typically they'll go in pretty easily, but we always want to make sure that we use that lubricant. We just try to think of the comfort of our patients, and of course, we don't want to cause any injury in that area either. So always be mindful of that. Now, with suppositories, we want to consider the most comfortable positions and the most ergonomical for these patients. So typically that's going to be our left lateral or Sims position. Now, if you see that on a test, you'll understand better what I'm talking about if you look in your book on page 61, if you don't know what left lateral or Sims position, if you can't recall that, it's on your book. So now, another thing you have to be mindful of when giving suppositories is you always want to make sure that you try and insert it just past that anal sphincter so that it just doesn't immediately come right back out. If it just comes right back out, they got zero absorption and it's not going to work. And if you did it right the first time, you don't have to repeat it. So just remind your patients also that they must remain in that left lateral position for about 5 minutes or so, just so that absorption can take place. Okay. Now, some things that are important to remember about vaginal suppositories, of course, are going to be positioning, and that's going to be your lithotomy position. I'll try and put a slide in that shows you that because I don't think that's in your book. Another thing is the use of an applicator. Most vaginal creams or medications come with an applicator, and that is because you have to insert it 3 to 4 inches inside the vaginal area. Now, this is extremely important for you to remember because absorption is important and it has to be inserted along the posterior wall of the vagina. Okay, so remember that. Posterior wall of the vagina is where we want to make sure we get it placed or inserted. And these patients also need to remain in that position for about 5 minutes to allow for absorption. And again, if you're using an applicator, always make sure that you're cleaning it in between uses. Okay, if it's disposable, toss it. Okay, and if your patient's going home with some type of applicator, make sure you're reminding them to also clean that in between uses. Now, enteral administration does have its advantages. We can give several different forms. Of course, we have tablets, elixirs, liquids, capsules, even powder solutions. Of course, you're going to mix those with some type of water, sterile water or something to administer that. So there's various different forms. Now, some things that we do have to take into account when we do oral medications is, of course, the pH of the stomach. And again, the bioavailability. So that's leading back to that first pass effect when we're taking medications orally. Okay, so many substances can be destroyed by the gastric juices and even some of the food contents in the stomach. So therefore affecting the rate of absorption. So we talked about several different things like grapefruit juices, milk, and caffeine, and then of course some fatty foods that affect absorption. So we have to be mindful in considering the pH, and we really haven't done so until now. So this is where we're going to begin talking about those enteric coatings on capsules to prevent that breakdown prematurely. So enteral drugs are the most common and the most preferred method of drug administration. Now, pay attention to this. As long as the patient is able or allowed to swallow. So if you have a patient who is maybe going for surgery or has some type of issue that they're assessing and maybe they're NPO, so they're not allowed to take anything by mouth, those patients are going to be getting medications either IM or by IV injections, okay? So always make sure that you're assessing their ability to swallow when you give oral medications, okay? Don't want to be giving oral medications to a patient who is comatose. They're not going to swallow them. So be mindful of that. Now, a couple of the other benefits as far as enteral drugs is, of course, their cost and they're convenient. Most of them are not as costly as some of the other forms of medication. So you're going to also find a greater compliance with patients who just take a medication by mouth and instead of someone who's taking one rectally. If I had to stick a suppository in my rear end every single day, I'm not going to be as compliant as if I can just take one pill a day and take it by mouth and be done, such as Tylenol. Okay, I would prefer to take Tylenol either by liquid or pill form rather than suppository. I would imagine each and every one of you would also agree with that. So some of the disadvantages also when it comes to enteral drugs, we always have to talk about disadvantages because there's no perfect medication administration and everything has its advantages and disadvantages. So of course, patients who are in some type of altered mental status, their consciousness, they're not going to swallow, as I mentioned before. Those patients who are maybe in ICU and comatose, they're not going to be able to swallow, or maybe even a patient who's had a stroke and they have some type of residual effects from that. They're unable to swallow without either choking or something of that nature. Now, we also have to talk about patients who are nauseous and vomiting a lot. So if you're vomiting and you're taking medications, how likely is it that your patient is even having enough time to absorb that medication? Okay, so always be mindful of that. If you have a patient who's nauseous and vomiting and their typical medication is by mouth, you may have to call a physician and say, hey, I have a patient who's vomiting profusely. Can we change this medication temporarily to a different route? Most of the time, your physician's going to be okay with that. Or they may just give you a medication to prevent the nausea or to treat the nausea and order another dose of that oral medication, a one-time dose. So one of the other disadvantages to enteral medications, of course, is it has to pass through the GI tract in order to get to their absorption site. So again, we go back to one, gastric emptying, and then that first pass effect. Remember, the first pass effect always takes away some of that availability of that medication. So for most drugs, the greatest absorption occurs where? In the small intestine. Okay, so remember we talked about absorption previously, and I think I gave an example about IBS. So when we're talking about absorption, if you have someone with some type of intestinal motility issue, how well are they absorbing that medication that's given? Okay. So now we talked about the pH and some enteric coatings, and we'll talk about that a little bit more. So there are, again, as I said, several different forms: tablets, capsules, powders, liquids. Now, when we talk about liquids, most liquid medications that you either purchase over the counter or given to you by prescription have a measuring device provided with them. That medication or that measuring device is specific to that medication. So do not use your kitchen spoons, okay? A teaspoon from your kitchen is not the same in measurement as it is when you get that measuring cup from the pharmacy or whatever, okay? Now, typically they will tell you it should be read at eye level on a flat surface. No, you're not going to see nurses doing that 9 times out of 10, but that is the true way to read that, okay? Because if you can ever actually take a look, most medications when they're in that little measuring cup sort of have a concave shape to them. So make sure you're reading at eye level on a flat surface. Now, of course, when we talk about liquid medications and those preparations, let's say amoxicillin, for example. Most children take amoxicillin for treatment of different infections. Those have to be shaken, okay? You have to shake it up really well because the powder settles or the particles settle in different areas, okay? So make sure you're shaking those. Those are always going to be on your label, so instruct your patients to read their labels. Some medications have to be protected from light. I know when I worked in the NICU, we would get certain medications, antibiotics especially, and it would say protect from light. So those medications are either going to come up in an amber colored bottle, or they're going to come up in an amber or a brown type baggie to protect that medication from light. So a couple different factors with Entral Drugs. Please make sure you're reviewing this, looking in your book, and then again, if you have questions, please let me know. Okay, so that is it for Entral Drugs on this slide. So we want to talk about some other things that are extremely important when we're talking about oral medications. So Entral is sometimes an extended release tablet or an enteric coated tablet. So let's talk about those. So extended release simply means that the pill has been formulated so that the drug is released slowly over time, okay? So some of the advantages of extended release medications are simply we take them less often. So hopefully most of the time there are fewer side effects by dosing fewer times. So how do they work? They work as either a sustained release, which you will see at the end of that medication as SR, or you will see CR, which is controlled release. So the drug releases over a sustained period of time for the SR, but it's not a constant flow. Okay, so the CR will always be released at a controlled rate. Okay, so they're going to have that continuous rate. It's going to be the same at all times. So that's the difference between an SR and a CR. Okay, so just kind of be familiar with the differences in those. So as you see, one of the examples, well, there's actually two on this slide. I have morphine sulfate, and it also tells you extended release in red lettering. So you know, also Tylenol is an arthritis medication, and we normally take Tylenol about every 4 hours. So with this one, you can see it is also an extended release tablet. and we only take it every 8 hours. Okay, so our liver is going to thank us for dosing less and less. So one of the advantages to extended release, of course, is hopefully just reducing the abuse of pain medications. Okay, so if they're getting that extended release, their pain medication is lasting a little bit longer, then hopefully you're not going to see them take that morphine as often. So we're hoping by extending the release, we will head off some of that abuse. So with the knowledge that this medication is for the purpose of a controlled release, we have to be mindful of not crushing those tablets, because as you understand, if they're broken or we cut them in half and they're not meant to be, or we crush them to give to a patient, well, that drug absorption is then so rapid that you're going to start seeing adverse effects. Okay, so at that point, if we crush a morphine tablet and give it to our patient, what does morphine do to a patient? Yes, it's going to decrease their respiratory drive or their respiratory rates. Okay, so we don't want to give them 75 milligrams all at once if it's meant to be an extended release tablet or capsule, because at that point, if you've depressed their respiratory system, you might be running to grab the crash cart. You just don't know. So just be mindful of never crushing those, especially pain medications. Okay, always check with your pharmacy if you have questions, or a physician if you have one in-house and you have questions. Just always be mindful of that, especially patients who have PEG tubes. If you're dosing that right into the stomach, it starts absorption immediately. Remember, those PEG tubes are surgically inserted into that stomach area, and so your absorption starts immediately. So be mindful of that. Now, this leads us back to a couple of reasons that we do not leave our medications at the bedside. Okay, so first of all, was your patient able to swallow them? Or are they still sitting in their room trying to choke them down? Okay. Did your patient not understand? You have a dementia patient, maybe that you've just left your medication at the bedside for. Did they chew it? They sometimes don't understand, like vitamins we chew and medications we shouldn't. They don't know that. So always be mindful. Remember, you are the person who's responsible. Your license is on the line for delivering that medication safely to your patient. So you've documented that they took it. So did they take it appropriately, and did they really take it? Maybe that person didn't or wasn't able to swallow as well, and they just spit it back out. Did they really get that dose, that extremely important dose of medication that they needed? Okay, so those are just a couple of things that as you start to move through pharmacology and become a nurse, you need to understand why we tell you those things. Okay, it's important. You're responsible, and your license is on the line. And again, this goes back to medications that you didn't draw up. We've talked about that before. If someone comes to you and says, hey, I have an emergency in room 12, I need you to give this medication. It is perfectly fine for you as a nurse to say, you know, I'm not going to do that. I will be happy to give that medication to your patient, but I'm going to draw up my own dose, or I'm going to pull my own medication for that. It is perfectly fine to help your fellow nurses. Just make sure you're protecting yourself at the same time. Because what if that nurse was in a hurry and she pulled the wrong medication? Remember, we talked about Tallman lettering. What if she didn't pull the right concentration, or it was a medication she had to mix and she mixed it inappropriately, or she mixed it with sterile water and it should have been normal saline? So those are things you have to consider as you start to practice protecting yourself, okay, and your patient. You work hard to get your license, and you don't want to see it go down the tubes just because you give a medication that you did not prepare yourself. So if you didn't prepare it, it's perfectly fine to refuse to give that, but also in the same breath say, but I will pull my own medication and give to that patient. Unless you see them and you double check that medication yourself, don't ever, ever give it. Okay, so be mindful of those things. So again, extended release, just know that you should never crush or chew those tablets, and understand the reason for that, not giving those. So if it's meant to give you a long-term effect, you crush it or you chew it, it's going to give you every single bit of that effect almost immediately. Okay, so you've defeated the purpose of that enteric coating or that extended release. So you can see on the label, this is important about reading labels again, it specifically says, and hopefully you're encouraging your patients to also read the labels, do not crush, chew, or dissolve. And again, this one says protect from light and moisture. Okay, so it tells you, how to store this medication and things like that. So always be mindful of educating your patients. Education is going to be a part of your nursing career from day one until the day you leave or retire. So again, just making sure to educate your patient on those. So this slide just gives you a picture of enteric coated medications. So enteric coating is just a method used to prevent that rapid degradation of medications once it reaches the stomach. So it basically just prevents the drug from being released in that acidic condition. Or we all know that the stomach pH can break down just about anything pretty quickly. So we don't want that with certain medications. We want it to actually reach the small intestine. So the greatest amount of that medication is absorbed in the small intestine rather than reducing that availability in the stomach. So you'll see I have the enteric coated and the non-coated. So it just kind of gives you an idea of the availability for absorption when you have one that's enteric coated versus one that is not. Okay, so it shows you that 80% of those ingredients are destroyed, only leaving 20% of that medication for absorption. So if you have a patient who's only getting 20% of that medication, and then it's going through the first pass effect, how much of it are they really getting? So the enteric coating medications are truly an advantage in certain cases. So you can see they're getting 60 to 80% of that medication, or 60 to 80% is actually available for absorption once it reaches that small intestine. So you can see the huge differences there. Now, I got another picture here at the side. You can see that the shell, that all-natural shell, or the barrier, is what prevents that breakdown. Okay, so once that shell dissolves, then you can see the medication, of course, in that picture is where it's contained. So they're purposeful in minimizing also side effects in the stomach, maybe nausea or gastric irritation, and even some bleeding in some cases. Okay, some enteric coated, maybe aspirins and things of that nature. So it's beneficial as far as preventing some of those side effects in the stomach. This is especially useful for medications that may be taken at night. A lot of medications are administered at night. So if you can imagine your patient taking a medication that is enteric coated at night and then laying down and going to sleep, what that might do to their stomach, because at night our metabolism slows down, and so it's just kind of hanging out in that stomach. So imagine what it can do to the inside of that stomach if it weren't for that enteric coating. So that enteric coating is important just in reducing, again, those ulcers, that nausea and vomiting, and things like that. And actually the availability, okay, that is one of the advantages. So just kind of be mindful of your advantages and disadvantages to the enteric coating and what that actually means for your patient when it's enteric coated. If we were to crush or chew that, how does it differentiate in absorption and side effects? Now, these types of tubes are used for patients who are either unable to swallow, such as your neonatal patients. They can't swallow tablets, so we have to have another way to administer those medications. You also may have a patient who has severe nausea that is unresponsive to treatment or has not responded to any type of treatment at all whatsoever. Or maybe you have a patient who has a bowel obstruction, but they still have to have some type of nutrition. So they will either, one, consider a PEG tube, or they'll do TPN and lipids through an IV. So it could be either or, but just know that a bowel obstruction is also one of the reasons to consider drug administration by NG or PEG tube. Now, when we talk about these tubes, again, you have to consider the extended release tablets that we talked about previously. Remember, we don't want to crush them and give those because they're meant to be released over an extended period of time. Remember, so we talked about if you crush that, they're going to get that full 500 milligrams immediately. So your best action is really to contact your physician and ask for a different type of medication. Now, with doing so, you may have to dose that more often, but you're not going to immediately give them 500 milligrams of Tylenol. Okay, so check with your physician. They're probably going to change the dosage. Or if you have an IV access, they may change it to IV access depending on what the medication is. Okay, so now prior to administering any medication through an NG tube or a PEG tube, you always have to make sure you're, of course, giving the correct medication. So you're going to verify your order, and then you always want to verify placement. Now, your PEG tubes, most of those are surgically secured, but your NG tubes can migrate. Okay, when you have neonates, we were forever having them pull them out and having to reinsert them, or it can actually just coil up in that GI tract. So always be mindful of checking placement for those. So when you're checking placement for an NG tube, you're going to insert, usually with neonates, we did about half a cc of air, half to one. With an adult, you may have to use a little bit more, but you're going to actually attach that syringe to the end of that NG tube, and you're going to, insert the air, and you're gonna listen for that swooshing sound. And some of you may have heard that, but it just sounds like a swoosh when you're listening for it with your stethoscope. Okay, now you want to make sure and always check your protocols with your facilities. They may vary. Typically, they're pretty standard. Some facilities prefer that you pull back some stomach contents and check the pH to make sure that you are, in fact, in the right place. Now, by doing the pH, that gives you a more accurate, absolute, yes, I'm in place, than just hearing that swishing sound. But 9 times out of 10, if you hear that swish, you're in the right place. Okay, so now when you're starting feedings for this particular patient, or I say feedings because we used to feed our neonatal patients by NG2 also, but when you're giving medications or feeding, however, or whatever you're giving, you always want to make sure that your patient is upright, okay, or at least in that semi-Fowler's position. And why do we want them in that position? Well, because you have a tube in the stomach, and if they're laying flat, what is that going to put them at risk for? Okay, think about that for just a minute. When you're laying down and you're trying to maybe drink water through a straw, where does it have the propensity to go to? It has a high potential for harm because it can actually move back into your lungs. So then if we have inserted, or if we have medication or even feedings that are going back into the lungs, then we're going to probably start seeing some aspiration pneumonia. And we don't want to do that. So we always want to, safely position our patients. Okay, now this does say you need to dilute medications in liquid in addition before flushing and after. Okay, and that is so that your tubes don't clog. Okay, we don't want to traumatize our patients anymore by having a clogged tube simply because we did not flush them appropriately. Okay, so always make sure that you're dissolving a medication if it's in tablet form. Make sure that if you're crushing it in order to dilute that it is something that can be crushed, not the extended release or anything that's enteric coated. Okay, so make sure that you're flushing with an appropriate amount. Okay, now some medications, it may already be in liquid form. So if they're receiving a feeding, you're typically going to just do the feeding, and then of course if there's suction of some type, you always have to turn that suction off for at least 30 minutes before you give medications with an NG tube or a PEG tube. Okay, always make sure that you turn that suction off. Now, of course, we have to take into account when we're diluting medications that each and every medication should be diluted separately. I know many times I've seen it myself that they're all crushed together and diluted in the same liquid and instilled through a tube. But remember, we talked about certain medications and how they're not always compatible because they can cause precipitates and block that tube completely. Remember, so that just goes back to we don't want to have to reinsert these items because it's stressful and it can cause some injury to that mucosal lining in that esophagus and that nasal area. So we don't want to have to reinsert them. And we certainly don't want them to have to go back to surgery to have another PEG tube replaced. So now we talk about dissolving medications. Do we dissolve them in tap water? No. Have I seen it? Yes. But typically we want to use sterile water or just some normal saline to dilute those in. Some drugs have a particular one. So always, again, check your drug guides, okay, or call your pharmacist. They'll tell you either way. But remember, you want to do each one separate, okay, and you want to flush before and after inserting those medications. Now, when we talk about using NG tubes and PEG tubes for feedings, when I worked in the NICU, we always had to check residuals, okay, and this varies from hospital to hospital. So again, check your protocols, okay. We would always check residual amounts. We would pull up whatever stomach contents was in there. If we fed our infants every 4 hours, then before we fed the infant, we would pull that residual amount. Now, if there was more than half a feeding left in that tube, then we might hold that next feeding because they're having some type of issue as far as stomach motility. So we would hold that. So it just depends. Now, NG tubes are typically, you can either feed them by gravity, depending on the amount, or they can be hooked to a feeding machine. Gosh, I'm lost for words. A Kangaroo Pump, just like an IV pump, but it's for feedings to regulate the amount that they get. Now, once you actually insert that, you're going to add 50 mLs of water or normal saline, and again, checking your policy, okay, when you're cleaning out those tubes. If you can imagine, we're not going to put 50 mLs into a neonatal patient who weighs 10 pounds or 5 or whatever, okay? 50 mLs is a lot, so we do not want to flush with 50 mLs. Now, for an adult patient, that's probably fine. But just remember, once it's all passed through the tube, you're going to clamp that feeding for at least 30 minutes, okay? Especially if you're going to give some other medications. So make sure your feeding is completed for 30 minutes before you give any medications, so that way there's no interactions with the feeding and whatever medication you're giving, okay? Again, we talked about suction. You always want to make sure you turn the suction off 30 minutes before. And then, of course, leaving it off for a minimum of about 30 minutes. Sorry, a minimum of about 30 minutes afterward, okay? Now, both tubes have a cap or it's attached to it. So it's just like a little silicone closure or cover. Okay, so it's not just going to free flow back out. Okay, so just make sure after you give your feeding and your medications, you flushed it, that you actually make sure that those are closed. Okay, guys, in this picture, this is what I wanted you to visualize. So the one you see on the left, of course, is your peg tube, and that's the one that's surgically or placed surgically through the abdomen into the stomach. Okay, the nasogastric tube you'll see in the center is a picture of just a generic NG tube. Okay, you can see the little tick marks on there, and that's actually your measurements in centimeters. So you can see how far you've actually inserted the tube. And then you can see the little neonatal patient on the right with his NG tube inserted and his little tegaderm holding that in place. Okay, so I just wanted you to get a visualization of those two, and then you can see better on the NG tube, the little plastic top. The PEG tube is kind of the clear plastic covering, but it is actually closing off that PEG tube so that none of the contents are just going to spew back out. Okay, with that PEG tube, you always want to make sure you clean in around that site. Okay, yes, it is inserted. It shouldn't really move about, but sometimes they can. I've seen many infants, their PEG tubes just come right on out. But always make sure you're cleaning the site on those PEG tubes, okay? Keeping it clean. So with NG tubes, I want you to understand about measuring. Some of you may have seen this performed in a hospital setting. So I just want you to understand the measurements because you may potentially see this again. Okay, so basically you're going to take the tip of your NG tube, you're going to place it near the nose, you're going to pull it back to the earlobe, you're going to have to hold it in place, of course, and then pull that down to where the belly button right at that xiphoid process basically is in order to get that correct measurement. Okay, so it's going to be um, nose to ear to mid umbilicus or right at that xiphoid process. Okay, so you can see that, and then of course you can't just leave it flopping in the air, so you're going to have to secure it somehow. And typically they'll secure it with a tegaderm. That's how we always did it in the NICU. That may vary from facility to facility as far as how you secure that, but you always want to make sure you secure it. Now, again, when you insert that, the first thing you want to do is check placement, okay? Either by stomach contents, if you can pull any back, or you can do auscultation and use just a little bit of air to hear that swishing sound, okay? So with this, know your locations, how to measure, and then actually when you're charting, you should also, the little NG tubes come in different sizes. So you can have an 8 French, or you can have a 5 French, or I think those are the smallest two. But anyway, either 8 or 5 French, and some of them come in a 10 French also. But anyway, whichever one you so choose is based upon your patient. So always chart the French number and where you secured it, because those NG tubes actually have numbers on there as in centimeters or whatever. So if you have a neonatal patient, you might put it down to 12 centimeters or 8 centimeters, whatever. Ever how small they are, that depends on your measurements. Okay, so secure it, chart what French you used, and how far you actually inserted that NG tube. So when the next nurse comes on, they should be checking that to make sure it's still in place also. And then you just look at the measurements and make sure that it hasn't migrated, okay, or slipped out or anything like that. So just know how to measure it, secure it, and chart it. Now, one thing I will tell you is there are some NG tubes, especially NG patients that may be going home, neonatal patients especially, that are still maybe going home with an NG tube because they've been scheduled for a PEG tube placement, but in the meantime, they've opted for a weighted tube. So you can have a weighted NG tube inserted, and those are always verified by X-ray. So there's a little tip in there that has, I guess, some type of metal content. I'm not sure what it's made of, but it's X-rayed to make sure that it is in place. So once it's in place, the weight of the tip of that tube holds it there. Okay, so it's not going to migrate back out, although it is still secured to, the cheek or the nose or whatever. But there are weighted tubes and then just your regular NG tubes. So you saw the regular NG tubes in the other slide. So they're just a little flexible round, tube with different French sizes. So just know the difference in an NG tube and a PEG tube and how to measure and insert those. I think 90% of this I talked about in the previous slide. Again, checking placement, checking residual, how you assess residuals. So in assessing residuals, is the amount greater or less than the amount that was ordered previously? So if I'm feeding an infant 10 mLs every hour and I'm checking his residual every 4 hours. So if at hour 4 I check it and there's still 30 mLs, then I'm going to have a 30 ml residual. So he's very slow to process. So again, clamping that NG tube 30 minutes prior to medication administration, stopping feedings, whatever suction or whatever. So the process is you're going to stop that feeding when you're going to give a medication or suction. You're going to attach your syringe, and of course, the NG tube has a clamp and unclamp on it. Our neonatal ones did not, but most adult ones have a way to clamp and unclamp. Okay, so like I said, you can let it run by gravity, or you can use the Kangaroo feeding pumps. Again, flush with 50 mLs of sterile water after medications, and again, clamping that NG tube for 30 minutes after flushing. Again, we talked about suction, so you want to shut that suction off 30 minutes prior to medications, okay, and then you want to leave it off so that it doesn't suck your medication right back out, okay? Now, medications are mixed in water. That is not tap water, as I said. That's going to be sterile water. And then you're going to flush with 50 mLs or whatever your protocol is for that particular group of patients. Again, you're not going to give 50 mLs of water to a neonatal patient. Okay, so keep it clamped, turn the suction off for 30 minutes after medication to allow for that absorption. Okay, so just kind of revisiting some of the things we talked about in the previous slide. Make sure that you understand this. You will see this again. You will need to know how much to flush with, how often to stop and restart suction, and those type things. What is the solvent that you use, or what is, what is the dilute or the solute that you mix with medications? Again, it's going to be your sterile waters typically. Okay, so don't just use tap water. So just revisit those and make sure you understand clamping, unclamping, suction, when to turn it on and off. Okay. Okay, so when we talk about parenteral drugs, we're talking about intradermal, subcutaneous, intramuscular, or IV. So what does this allow for? What are the advantages? It bypasses any part of and all of what? The liver, the GI tract. It bypasses the first pass effect. Okay, so you're not seeing that reduced availability of that drug. Okay. Now again, these we always talk about the advantages and disadvantages of certain medications. Of course, with your parenteral drugs, you're going to have that immediate action. Okay, and one thing to be mindful of is swallowing. Your patient can't swallow for whatever reason, or they have some type of maybe a disease process in the GI tract. Okay, remember, always keep that in the back of your mind when you're talking about alternate routes of medications. Okay, so if they have some type of stomach cancer or an ulcer or whatever, you know, they're being treated for, and absorption is just not up to par, then we have to change those medications to be absorbed in a different way. So upon assessment, okay, they can't swallow. This is a couple of other options for drug medication administration. Now, parenteral drugs are great when it comes to taking care of those patients who are in a code situation. They come into the ER and you need to give a drug stat. You want to establish that IV. And if you don't have an IV, you give it, you know, however, whatever is the easiest way to get that medication quickly to that patient. Okay, this again just prevents the bypass of the stomach and destroying those, the bioavailability or the availability of those medications when it passes through those gastric enzymes. Okay, of course, I think I use the example of morphine. One of them is morphine, and how nearly 70% of it is rendered ineffective or unavailable once it goes through that first pass effect. Okay, so that's where you start to see those higher doses. So it prevents them from being exposed to those gastric enzymes. Okay, now this is where we talked about when we were referring to peak and trough levels, and we're monitoring medications because we need them at a therapeutic level. Okay, so a steady drug level is needed, and most of the time this is your patient who is in a facility, and let's just say they're getting antibiotics, they've had a positive blood culture. Okay, so we need that antibiotic to have a steady level in order to fight off that infection or to get rid of it. So we're going to give that medication by IV. Okay, that's you'll see here where I talk about frequent dosing of antibiotics. And we're going to do peak and trough levels. Those are your labs that tell you, are we in a therapeutic range? Are we above or below? Okay, and remember, your peak level is drawn shortly after that medication is given, usually about an hour, and your trough levels are drawn just right before you give that dose, that next dose of whatever that medication might be. Okay, typically antibiotics or drugs that are not available in any other form. Let's talk about doing a TB test. How do we give that one? Okay, can you take a TB test by mouth? No. So we're going to do an intradermal. Okay, that's when you have a little bleep under the skin, and everyone who works in healthcare typically has to have a TB test. Okay, there's no other way to test for it, so it's not available in any other form. So you're going to use it, you're going to test by a parenteral drug. Okay, so that's kind of the basis of parenteral drugs. Now, when we talk about parenteral drugs and the different ways to dose them, I want you to be keenly aware of the fact that dosing by IV is immediate. Your patient is going to start to feel or see immediate responses to those drugs. It is entered into that circulatory system as soon as you inject it. Now, can you suck it back out through a syringe? Because the minute you start to give it, you're like, oh my gosh, I totally gave this patient the wrong medication, or that's not the medication I thought I was giving because I failed to look at it 3 times before dosing. No, you cannot. Once it has entered, you cannot pull it back out. So be well aware of the safety issues when giving parenteral medications. And what is your responsibility as a nurse? Once you're on the floor and you gave it, you've already given it, and suddenly your patient starts to have, you know, whatever. Let's just say you gave the wrong medication and you're starting to see signs of anaphylaxis. What are you going to do? What is your responsibility as a nurse? First of all, you're going to check the status of your patient. Okay, you're going to stay with your patient, and then you're going to call for help report it to your nursing supervisor, your shift leader, and then you're going to immediately call that physician. So we talked about IV. Let's look at some subcutaneous. This is going to be where you're going to give insulin and your heparin. If you have a patient who is maybe on blood thinning agents because they're bedbound or whatever you want to call it, and they're at risk for, of course, thrombosis. So they're getting some type of heparin, or your patient needs insulin. So you're going to give those injections subcutaneously. So you want to select the site that has an adequate area of fat. So a lot of times we'll use the abdomen. Okay, you can use the abdomen. Sometimes we'll use the back of the arms. Okay, upper hips, or maybe even the thighs. But typically, you'll see those given in the stomach, back of the arms. So those are going to be your sub-Q injections. So if you'll look on page 49, there's a figure 414 that will show you the sites in which we can typically use for subcutaneous. I've never really used the back of the shoulders. I've never seen it given that way. So just be mindful of the fact that it's available. It's just probably less used or widely known to be used for sub-Q injections. You always want to make sure that for sub-Q injections, typically you're using a 25 or 27 gauge needle. Those are really small, especially if you're someone who's receiving insulin. You don't want to stick yourself with an 18 gauge or anything like that. So that's where the importance of knowing your gauges come into play, and when you use them appropriately. Okay, so that's going to be your sub-Q injections. Now, for intramuscular injections, this is a lot of times where you're going to see those vaccines given. Any type of irritating medication. I know one particularly, it's an antibiotic, Rocephin. Heavens to Betsy, if you've ever had it, you'll never forget it. It's extremely painful. Even if it goes into the muscle, you can still feel it. It hurts, it burns, you'll never forget it. So they use a lot of, or they use IM injections for a lot of medications that can be irritating, like those. Some of the common sites, again, are going to be your deltoids, your vastus lateralis, especially in those pediatric patients. And when I tell you these sites, make sure that you're understanding where these locations are, okay? And you need to know your landmarks for those injections, okay? So make sure you look at those. On page 50 and page 51, you can see some of those, okay? Of course, the vastus lateralis is what we use in most of our pediatric patients because that's the most developed muscle that they have. You can also use the dorsogluteal, the ventrogluteal, just a couple of those. Now, one thing that you have to be extremely mindful of, and I mentioned this in the study guide, was what do you do if you have to give a medication to a very large adult and you're giving more than 1 to 3 mLs? Well, we're told that 3 mLs is the range or the maximum amount that you can give in one injection site. So either one, you're going to have to give a different medication, maybe that has a lower ml content, or you're going to have to give 2 injections. Now, you can't give 2 injections in the same site. You have to give 2 injections in 2 different sites. So if I have to give a total of, let's just say, 4 mLs, I'm going to give 2 and 2. I'm going to give 2 in one deltoid and 1 in the other. Or you can do 3 and 1. It doesn't matter. But you cannot give any more than 3 mLs. Please make sure you remember that. Write it down, whatever. So just if you're giving more than 3, divide it into 2 syringes and 2 separate sites. Now, I vaguely mentioned intradermal and the TB testing. Okay, so with TB testing, typically you're going to use a TB syringe. Okay, it's teeny tiny, very fine. So if those are not available, you can use a 27 gauge. Okay, It's just right under the skin. Typically, those are on the forearm that we do. Bevel up, of course. You always want to make sure your bevel is up when you give any type of injection of that sort. And a small bleed will appear. It's almost like a little blister. Okay, so if you hear the word bleed, you'll know what that is. Now, when you're giving an intradermal injection, you do not massage that site. Okay, so don't massage that intradermal injection. Okay, so those are the four parenteral routes. And so we've talked a lot about those. Make sure you understand the sites, the amount that you can give, and the safety issues with each individual route. Your IV, of course, is going to have your highest risk for patient harm because if you give it, you can't retract it, okay? And it is immediate. Now, if you give it intramuscular, of course, we want to get it deep in that muscle, and it's very, it has a lot of blood flowing through there. But we sort of have a little bit of time, we might be able to head that off. But that IV is instant. You cannot take that back out once you've given it. Okay, so that's where it's important for you to triple check those medications before you ever give them. Okay, now one thing I do want to mention is when you're giving an IM injection, nobody likes to receive an injection with a dull needle. Okay, so if you've mixed up an antibiotic, let's say you're going to give ampicillin, and you've mixed it up and you had to pull your sterile water or whatever your solvent is to insert it into your bottle that you're mixing. So you've used that needle to enter through the rubber part of the bottle. Do you really want to use that same needle to inject into your patient's arm? No, absolutely not. So if you mix it, then you need to change your needle. So you have a fresh needle. There was no risk of infection or, contaminants getting onto that needle. And again, you're going through rubber. So who's to say that you didn't pick up a small piece of rubber when you were inserting the sterile water to mix it? Okay, so always make sure you change your needle. You don't want a dull needle. I don't want a shot with a dull needle. So don't do that to your patients, okay? Now, also, I want you to be extremely aware of the fact that we never, ever, ever recap a needle, okay? Don't do it. That is where you're going to start running into your finger sticks or, needle stick injuries. Just don't do it, okay? Do not recap a needle. So always change it if you've had to mix a medication and never recap. And last but not least, anytime that you're giving any type of injection, you always want to make sure that you're using aseptic techniques and you are wearing your gloves. Okay, that's not only to protect them, but also to protect yourself. Okay, so anytime you break that skin, it's always an entry point for infection. So as long as we're using the aseptic technique appropriately, we're reducing the risk of infection. Okay, so be mindful of wearing your gloves, any other PPE that might be involved, and using that aseptic technique. Okay, that's extremely important. We don't want to introduce anything, and of course, we don't want to stick ourselves and have to go through all that testing either. So be mindful of those safety issues. Again, I guess I got ahead of myself, and just about everything that is on this slide I've already talked about. So IV immediately enters that bloodstream directly. It's very fast acting. Intramuscular must be absorbed into the muscle prior to circulation, so it's a slower onset than an IV, and you're going to see slower reactions. So the room for error or the room for correcting an error is very small when using IV versus IM. So precautions, I talked about that. Do not recap needles, wear your gloves, use aseptic technique to prevent infection. Okay. So initiating actual IV systems is typically not within an LPN practice in most states. This is why I really wanted you to look at your Nurse Practice Acts and the LPN role within those, your can and can'ts when it comes to medication administration, so that you're familiar with that when you get out practicing on your own, under your own license, okay? Many times LPNs assist with IV medications or intramuscular drug administrations, okay? But they're not solely responsible for most of that. Now, again, you did see that if an LPN has practiced within 6 months, they've gone through the education and proven competency, then some of those restrictions are lifted, but only when proven competency is documented. So we have a couple of different things. We have piggyback deliveries, we have IV pushes, we have IV bolus, we have intermittent, and then we have continuous infusions. Now, with intermittent and continuous, that can either be medications or it can also be feedings. Okay, so be mindful of both of those. So intermittent just typically would be like an antibiotic infusion. You're going to give that intermittently, like every 6 hours or every 8 hours. Now, a continuous infusion would be something like your normal salines or your lactated ringers, something of that nature, or a heart medication or a blood pressure medication, something that we would use in an ICU to keep that blood pressure at a certain level. Okay, so those are going to be your continuous infusions. Okay, if you stop that infusion rather than weaning it, then you're going to see probably some severe repercussions from that. So know the difference between intermittent and continuous. Feedings are just the same. We may feed that infant every 4 hours. Or we may have continuous feeds. Okay, so they're getting a continuous amount, maybe 5 mLs or 10 mLs every hour. Okay, so it's going to be a continuous rate of infusion. So those are the differences in that. Now, IV push is just you're giving a medication and you're just pushing it through that line. Now, if you don't remember your restrictions as far as your what you're able to do as an LPN, please refer back to those. I made you handwrite them for a reason. If you handwrite it, you're going to remember it. Okay, so an IV push. Now, when you are looking at medications to give, you want to refer to your drug books. If not, call your pharmacist or your pharmacy, no matter what time of the day or night it is. Some medications you cannot push. Fentanyl, do not push it. I know that was one of the biggest drugs that I was so fearful of giving too quickly when I worked in the NICU. If you push fentanyl, one of the biggest side effects of that is chest wall rigidity. And if you don't know what that means, look it up, or I will just tell you. It simply means that you're going to get a truly rigid lung capacity. Your lungs are just rigid. You're not going to be able to move that air in and out. So what does that say? You're going to have a very hard time oxygenating that infant. You're going to see your oxygen stats start to drop. You're going to see that heart rate drop, and then just don't do it. Okay, so if it says push slowly over 5 minutes, which typically when you look in your drug book, it's going to tell you it's an IV push or an IV slow push. Now, slow push should not be written in the orders ever, because that leaves it open to interpretation. So slow for me might be 5 minutes, but slow for you might be 1 minute. Okay, you don't want to wait around for 5 minutes. So just know the difference. The push will tell you. It may be a slow push and it may be 5 minutes, but it should give you a time frame, 5 minutes. Okay, a bolus is simply a one-time infusion, typically a bolus of maybe normal saline. Your blood pressure is bottoming out and you have an infant who just needs some volume. Okay, so you're going to give a bolus. You're going to give a normal saline bolus or food bolus even. You can do feeding boluses. Okay, so know the difference in what those are. Now, piggybacks are just that. You have maybe some type of normal saline with some electrolytes going, and you're going to give an IV of or and you're going to administer, let's just say, an antibiotic. I use those a lot. So first of all, you want to make sure that it's compatible with whatever you have going through your other line. Okay, so always check the compatibility so that you don't clot off your line or cause precipitates and then have to, you know, try to find another access. So piggyback, just one medication infusing while you have other medications going. Okay, so go back and revisit your LPN instructions on giving piggyback medications. Okay, so that was one of the purposes in that assignment, is so that you're familiar with giving those infusions and knowing what you can and can't do. So I want to go back to IV pushes for just a second. Sometimes you may just be giving an IV push through just a peripheral IV, which is just a regular saline lock. So check with your facility on requirements for that. Some have a time limit. They may only have them in or allow them to be left in 48 hours. Some may have 72 hours. And others may just say leave it in until it no longer flushes. Okay, so when we're talking about an IV push, you're going to push that medication slowly. But remember, when you have that IV line in there, you still have a minimum or amount of tubing that's in there, especially if it's a central line. Okay, you may have about 6 inches of line that is going into your patient's body. Okay, you don't see it, so you don't always think about it. But you have to be mindful also is when you push your medication, that whole 5 minutes, you also want to make sure that you're slowly flushing with that normal saline behind it. Okay, so if you have 6 inches of medication still left in that line and you go in there and you just push your saline quickly, what does that do? You've basically rushed that medication through the rest of that line. So be mindful of slow pushing and flushing slowly also. Typically, those lines are flushed every 8 hours, whether they're used or not. Okay, so please be mindful of those time frames. 8 hours minimum. Flush them whether you use it or not. Now, piggybacks. The one thing with piggybacks you have to be aware of is when we're piggybacking a solution, your piggyback medication, your antibiotic, needs to be higher than the other medication that you're giving, okay, or it's not going to infuse correctly. So it should always be hanging higher than your other medications. So while we're talking about IV systems, let's talk about tubing. So you have two types. You have macro drip and you have micro drip. Okay, so if you look on page 53, you'll better understand this as I go through it. Okay, so you have a macro drip tubing, and it is set at either 15, 20, or 10 drops per ml. Okay, so now a micro drip is set to deliver 60 drops per ml. Okay, so look at figure 420 on page 53. So I kind of want to help you visualize this. I know it's hard when we're not in class, but the easiest way to remember this is with your macro drop tubing. You can see the drops are larger. Okay, so you can deliver 10, 15, or 20, and that's going to be per ml. Okay, so the larger the drops, okay, the faster it's going to deliver. Now, when you're looking at your micro drip, you can see, if you can visualize it, it's very, very small, but you have 60 drops that flow out. Okay, so those teeny tiny drops probably are not going to equal 20 drops in your macro drip. Okay, so if you want to infuse something quickly to a patient, you want to use your macro drip. Okay, so the larger the drops, the quicker it's going to get to your patient. Okay, the more you're going to be able to give. I know it sounds as though 60 drops per minute or per ml should deliver quicker, but it's not, because your drops are larger in that macro drip. So it may be 20 drops per minute, but you can see it's going to deliver quicker. So with microdrip tubing, the tubing is wider. So that's why you're seeing those larger drops. And so the microdrip tubing is smaller. Okay, so this would be something that you would use for children or infants, or if you're infusing something that's very irritating to the skin, very sensitive medications where you want to better control the flow. Okay, so you're going to use the microdrip tubing. Sometimes it's called a mini drip, but just remember that it's important for us to use that micro drip when we're instilling a medication or infusing a medication that may cause some hypersensitivities at the injection site. Okay, for children, just be mindful that micro drip is going to give us better control of the medication that we're administering. So I wanted to give you a visualization of macro versus micro. Okay, so you can see in the macro tubing, the drops are larger, and that's because of the diameter of the tubing. And so you can see that 3 drops in a macro tube is more or less equal to 5 to 6 drops in a micro tubing. And I've kind of given you a couple of examples over here. So which is going to be the most accurate? It's going to be your micro tubing. Okay, so that is why we use the microtubing specifically for children or medications that we want the most accurate dosing and the least amount of error. Okay, so when you're rounding drops, of course, you can't do half a drop, so you're going to round to the nearest drop. Okay, so now if I'm given a medication, let's just say, for instance, a cardiac medication or something that could be very toxic, then I most certainly want to use those micro tubings because the drops are smaller and it's going to be a lot more accurate. Okay, and you can also see at the bottom I talked about the sensitive medications. So if I'm delivering a medication in through an IV and I deliver at a slower rate or a smaller dose, at any given time, it's going to be less sensitive to the area of infusion. So just keep those things in mind when you're looking at those the differences in quickest delivery versus safest delivery. Okay. So one of the other things you can see here that I've talked about with the macro tubing, it's larger. So let's say if your drip rate is 10 drops per minute, okay, it's going to take you a lot less time, of course, with the macro tubing to reach that 1 ml than it would be for the micro tubing dripping out of 5 drops, even though you're getting 5 drops, they're smaller. Okay, so try not to confuse those. You can see I have a couple of examples over here, and you can just kind of look at that. So just be mindful of, even though the number of drops are greater, they're smaller than the number of drops with a macro tubing. So don't confuse the two. Just because the drops are larger in number does not mean they're larger in volume. Okay, because you will have some test questions about macro tubing versus micro tubing and safe dosing. So one of the biggest takeaways from this is which tubing is most accurate and why, and who and what medications you would use those for specifically. So again, just going back over that macro drip tubing, it's wider, so it produces larger drops. Okay, so this is just typically used for normal IV administration of fluids, your normal salines, your half normal salines, and things of that nature. The medications that are not very sensitive medications, such as maybe your cardiac medications or antibiotics and things like that. So they're are 3 different sizes. So you may have to calculate a math problem in which you use either 10 drops per milliliter, 15, or 20. Okay, so those are the sizes that your macro drip tubing are supplied in. So know those, know why we use macro drip the types of medications that we can infuse or typically infuse through the macro drip tubing. So on to micro drip. So just reiterating the fact that the micro drip is just that. It is narrower than the macro drip. So it produces a smaller drop. So this is the tubing that we specifically want to use for children, infants, and those sensitive medications so that we're a little more precise in our dosing rather than those larger tubings, the macro drips. Okay, now sometimes they may be called a mini drip, and that's fine, but there is only one size for a micro drip. So if you have a test question and it asks you to select, you know, how many drops per ml does microdrip provide? You're going to know that it's 60. There's only one size for microdrip, okay? So the smaller the drops, the more accurate the measurement. So one last slide here just to reiterate the micro versus macro. Okay, so macro is often used when you want to deliver those medications faster, when you have a fast infusion rate needed. If you're trying to get someone's blood pressure up and you're infusing a bolus and you want it in there ASAP, you're going to pick a macro drip. Okay, so now don't confuse your drops and your infusion times and rates. Okay, so the macro drip is set for us to deliver a specific number of drops per ml. Okay, so don't get confused with mLs per hour or mLs per whatever. Okay, so I need my medication to be most accurate, so I'm going to use that micro drip. And so if you can't remember anything else and you want to go faster and larger, just think about that big giant Big Mac Daddy reference. Okay, so Big Mac Daddy is the one that's going to deliver it fast and with that larger tubing. So that's pretty much it for macro and micro tubing. If you have any questions about those or as far as calculating those math problems, please let me know. I will send out some practice problems for macro and micro tubing, so just be on the lookout for those. So this is just an example for accuracy. If you guys will just read through that. This is again just reiterating the fact that even though I have 5 drops coming out of a tube, does not mean that I'm delivering it quicker. Those drops are smaller than the 3 drops that are going through the macro drip tubing. Okay, so just kind of read through this and know the difference, know which is the safest and which tubing is used for what purpose. So the last note at the bottom is if you can't remember anything else, the larger the drop, the fewer there are needed in order to make that ml. Okay, so if I have 5 teeny tiny drops flowing, it's going to take a whole lot of those, let's say 100 to reach an ml. Whereas if I have 3 very large, it may only take half or 50 drops to get to 1 full ml. So think of it that way. So choosing appropriate syringes and needles. Okay, of course, I have said this so many times in the past. You probably already know this, but syringes, of course, are not always marked in the same unit of measure. So if you're giving heparin or insulin, you want to make sure you're using units. Remember, it's dosed by weight, not mLs. Okay. So if it does not have units marked on there, do not use it. Okay, it's extremely important. You could overdose your patient with heparin very quickly. Okay. Now, as far as giving TB testing, things like that, your syringes come in like typically 1 mLs, 3 mLs, 5 mLs, all the way up to 60. Okay, 60 mLs are typically used for either feedings or flushes, something like that, for administering maybe a bolus of normal saline or something of that nature. So those are going to be your 60 ml syringes. Now, when we talk about selection of needles, if you guys will look on page 45, you're going to see in figure 4.1 and 4.7, or table 4.1, figure 4.7, talking about needles, and you can follow along with this. So there's 3 parts to the needle. You have the hub, the shaft, and the beveled tip. So always be mindful of the fact that that bevel is up when you're administering an injection, especially one that is sub-Q. Okay. Now, as far as one last part of that is going to be the lumen. Okay, so the lumen is determined by what you're actually injecting. And the lumen is just referring to the how large or the diameter of the needle. Okay, so if you have a really thick medication, I typically use Rocephin because it's white and thick. So you don't want to be giving Rocephin through a teeny tiny lumen. It's going to take you forever to inject that medication, and it's very uncomfortable. Okay, so again, the lumen size is always determined by what you're injecting. Okay, and the length is determined by where you're injecting. Okay, so if you're going to do an intradermal, let's say we're giving a TB test, we want to use a 25 to 27 gauge. And it doesn't have to be long either. It's going to be like 3/8 or a half, okay, because you're just barely going under the skin to create that little bleep of for the testing where the medication is going to be inserted. Now for sub-Q, of course, this is going to be your heparin, your insulins. So you want them, also you're going to use a 25 to 27 because we don't need an 18 gauge to give insulin or heparin through, but it has to go a little bit farther than just the surface of the skin. Okay, it's not going right under the skin, it's actually going into the sub-Q area. Okay, now I will try and put a slide in here. You can kind of see the difference. So you can see the insertion angles and where it actually goes. Okay, so our sub-Q is actually going below the epidermis. So it's going right into the dermis just before that muscle layer, but below the skin. Okay, so I'll put that in there for you so you can kind of look at those. Now, intramuscular, you're going to use a 20 to 22 gauge. A lot of times this is for vaccines and things like that. So you're going to use about 1 to 2 inch needle. Now, if you have a big giant bodybuilder, you're going to probably use a 2-inch needle. Just varies. If you have someone who's of average build, you might get away with 1 to 1.5 on the length of that. Okay. Now, intravenously, the gauge, it says 15 to 22. I've never really used a needle for IV. I've always used a needleless system. Okay, so this is going to be your plastic needles. I don't know if some of you know what I'm talking about, but they're just the little plastic-like needles, and it would enter into the little rubber part of the IV portion or the hub of that. So as far as IV, I want you to make sure that you understand the volumes that can be injected. So with IV, you're going to have an unlimited amount that you can inject. Intramuscular, remember, you have to have 2 different sites if it's greater than 3 mLs. Okay, sub-Q is usually about, typically it's half a cc. I've really never seen one given that's more than half a cc. So be mindful of the gauge, the length that you would use, and how much you can inject for each of those administering sites. Sorry, I'm at a loss for words there. I was trying to look at my notes. So I'm going to put on the next slide the IM, the sub-Q, and the intradermal angles so that you can kind of see what I'm talking about and where they're going and why we use the length that we do. Okay. Again, always being mindful of using your alcohol to clean, wearing your gloves. Of course, you know, you're breaking the skin and we don't want to introduce any infective, anything that might cause an infection. So always be mindful of that. So I'll put that slide in here just so you can kind of familiarize yourself, especially those who have never really worked in the healthcare system, the syringes and the different calibration systems. So you have a 3 ml syringe, okay, so you're going to see those mLs. Units, this is again for your insulin and your heparin. You're going to see that units actually written on that syringe. It will never be abbreviated in U, okay, so if you give 10 units versus if you're looking at say a 10 ml syringe, you can see the massive impact that you would be putting on your patient as far as side effects or anything if you used a system that was calibrated in mLs versus units. And then you can see the TB syringes, they are very minute amounts. So you can see that 0.5 mLs or that 0.10. Okay, so you can see the different calibration systems for the syringes. So just be mindful of those that vary, that they do vary. So always select your syringe according to the medication you're giving. So this is what I was talking about in the different gauges, and you can see the diameters here, okay? The 15 gauge, the 18 gauge, the 20 gauge. That's the actual diameter of the needle, okay? How large they are. Most of your 15 gauges are going to be if you're doing like something really deep, like intraosseous and things like that. 18 gauge would be for like maybe blood donations, things like that, where you want a larger flow to, quickly. Okay. 15, 18 gauge is going to be for like blood donations and different things. So just review those, know the 3 parts of your needle selection, and that you should always give bevel up. So this is the slide I was talking about when I said I would give you an example of why needle selections are important. Okay, it looks like every single one of these needles have the same length, but I wanted you to understand the different layers that we're trying to reach when we're doing needle selections and the lengths. So for intramuscular injections, you're going to see that we're going pretty deep, and we're probably delivering vaccines, steroids, and antibiotics. So you're probably going to have a larger gauge, and you're also going to have a longer needle length. And you're also going to go in at a 90-degree angle. Okay, you're just going to go straight in. And I know that you guys talked about this a little bit with Miss Party, but I want to revisit this because you will see some of these questions in our on our test. So subcutaneous, of course, we're going right below the epidermis, and it's at a 45-degree angle. So if we're looking to insert sorry, I get tongue-tied. Insert an IV, you're going to see that our angle is about 25 degrees. Now, of course, we all know that not everyone has veins in the same exact location. Everybody's different, so you may have to adjust that just a little bit. But your intradermals are pretty much 10 to 15. They're almost parallel with the forearm. Okay, I use the forearm because we do allergy testing there, we do TB testing. Okay, now lidocaine is one. If you're going to remove, let's say you have I don't know, not a wart, but or you could remove a wart or anything, skin mole, a skin tag, or something like that that you're going to have removed. Your lidocaine is going to be an intradermal, so they're just going to go right in around the skin, around whatever they're removing, and inject that lidocaine to numb that area. Okay, so again, I gave you an example up in the top right-hand corner of different medications or drugs that they might be given IM. Subcutaneous is typically your insulin and your heparin. Sometimes they can do epi there, of course. If you don't have any IV access, they're going to give it to you sub-Q if they haven't established maybe an airway. So just be mindful of your angles and what angle you're giving or what angle you're going to go in at with whatever drug you're giving. So in our previous class, we talked about practicing this using an orange to mimic administration to patients. However, if you don't have, I don't know, some of you may have your nursing, the little bags that they give out to you. So if you have those and you want to practice, then by all means, you can do so. I don't know that we'll be able to get into the lab to do this given the circumstances, but we can always revisit this if they allow us to come back to campus and use some of those practice pads for administering these medications in different ways. So look on page 46 and 47 to talk about vials and ampules and some of the other mixo vials, okay, that you may see depending on what facility you work in. So a vial, of course, is just a regular vial of medication. This is going to be on page 46, figure 4.8. Okay, it's just a regular bottle. Typically, these are already mixed for you, and you're going to see it has a lid on top, and then of course it has the rubber diaphragm there. That's where you're injecting that needle to pull out your medication. Now remember, when you're pulling out that medication, you always have to do one thing first. Think about what that is. Yes, you want to inject your air. So if you're giving 4 cc's of medication, you're going to inject 4 cc's of air and then pull out your medication. Okay, one, so that we don't, it's easier to pull your medication out if you insert that air. And of course, we don't want to over inflate that bottle and risk breaking the bottle. Okay, so you just look at the process of that, okay, and giving that medication. And remember what I said, if you use a needle to withdraw that medication, always change it before you give an injection to your patient, okay? They'll appreciate it. I know you would appreciate it, so don't use the same needle to pull your medication and dose with. Now, vials can be a single dose or it can be a multi-dose. Now, when you're using a multi-dose, of course, you always want to use aseptic technique. You want to clean the top, let it dry. And a couple other things with a multi-dose vial are you always want to, if you're the first person who opens it, you want to date and time and initial that so that, you know, some medications may expire. Well, how do we know? Usually, these medications are good for 28 days. Okay, so when the state comes in, they're going to be looking for that. If it's a multi-use vial, they're going to be looking for the date that it was opened so that they can see, are you using this past that 28-day time frame, or are you tossing it once that 28 days has expired? Okay, single doses, just dispose of them properly once you've used it. Okay, don't use it again. So your multi-dose, of course, is insulin, and we talked about labeling. Please make sure that you're doing that. Okay, there's nothing worse than coming in because these medications are not inexpensive. Okay, so there's nothing worse than coming in and you can see the bottle's almost completely full, and probably someone opened it on night shift. But how do I know? Okay, how do I know when they opened it? I don't want to risk that, so we end up just tossing it. Ampules, you'll see on page 47, there are scored ampules and ringed ampules. And if any of you have ever used them, you know that it can be a bit of a challenge to pop that top off. So what's going to happen is you're going to pop that top off right at the scored area on that bottle. Now, always make sure that you're using 2x2s or something like that, because for instance, last semester when we did this, we did have one of our students cut themselves. I've actually cut myself trying to score or open that ampule, even though it popped right off where it was scored. Okay, so always use something to protect yourself because it is glass. They're always single doses. And now this is extremely important for you to remember. When you're using an ampule, I don't care what facility you're in, I don't care how resourceful they try to be or how much money they try to save, you should never, ever dose a patient with a medication that you drew from an ampule without using a filter straw. Okay? Do not do it. Because what can happen is you're breaking that glass. Who's to say that a little tiny piece of that glass didn't get inside that medication bottle? Okay, so always use your filter straw. Now, mixo vials are a little bit different. So these are already pre-mixed for you. They're already pre-measured. This is a vial that has two areas that are sealed off from each other. So you have your powdered contents in the bottom and then your sterile solution, whatever it's mixed with, in an area above that solution sealed off. So you're going to basically squeeze it so that it pops that first or the middle rubber part out so that you're able to mix the powder in the solution. Now, you don't want to shake it because you get a lot of bubbles in there. So you're just going to gently kind of roll it between your hands as if you were maybe warming it up. Okay, so just gently roll it for just a little while until you see that it's all the powder has dissolved or mixed. Okay, and then at that point in time, the outside rubber seal is where you're actually going to access in order to pull that medication out. These are always single doses, so just toss it when you're done. Okay, if at any time you're using any vial, any mixo vial, or anything else at all whatsoever, and you have a question about the seal, throw it away. Don't bother using it. Just toss it. I would rather toss it and take a chance as to use it and something happened to my patient. Okay, so just always toss anything that's questionable. Now, prefilled syringes, most of the time you will see normal saline come in premixed syringes. Some medications come in premixed syringes or prefilled syringes, and they have like a carpet injection type contraption. I hated to use them, but so there are a lot of prefilled syringes out there. So typically it is your normal saline, but just know that there are other medications that do come in those prefilled syringes. When you use them, toss them. A lot of times, prefilled syringes are going to be your emergency drugs, your epinephrines, or sometimes even opioids, just depending. So the carpet basically is just, you're just going to take your prefilled syringe and it kind of just screws into the um, carpet where it accesses the rubber part. Okay, and then you just inject it and toss it. Um, so some of you may get the opportunity to use those. If you never see one, count yourself lucky. I don't particularly like them, but just know that they're out there and they are available for use. So intradermal, I talked about this in a previous slide. TB skin testing. Many of us have already had a TB test in order to even get into nursing school. So you've probably seen what this looks like. So it's just the space between the dermis and the epidermis. Remember, bevel up. It's going to be on the inner aspect of your forearm. You can use the scapular area on the back or the upper chest. I've never ever seen a TB skin test performed on those two areas. Maybe if you had someone who was an amputee and didn't have a forearm, certainly they probably use those areas. I myself have never seen that. So, of course, intradermal is going to be a slow absorption method. And then again, that's where you hear me talking about that little bleed that it creates. And you'll see I have a picture here showing you exactly what it should look like when you give an intradermal injection correctly. Okay, so you're going to use that 25 gauge, very short needle, 3/4 of an inch. So short and small for TB testing. Okay, so you'll see on the bottom right-hand corner, you'll see that the results. Okay, so once you have a little bleed, If it develops into, X millimeters, it's positive or negative. Okay, and they usually check those tests within about 48 hours. So just remember that bleed, 25 gauge, short and small. Typically, this is only about maybe half a cc that they inject anyway, so it's a very small amount, even though it may feel like it's a little more than that because it's given in a sensitive area. It's about half a cc typically for TB testing. Subcutaneous, I talked about this a little bit a couple slides ago, given between the dermis and the subcutaneous fat layers, which is above the muscle. Okay, so I've given you a visual so you can see the difference in giving a sub-Q injection and an IM injection. Okay, so probably if you've ever worked in a facility and you've seen heparin or insulin given, those are your two most common sub-Q injections. Typically, insulin varies depending on blood sugars and whatever their chart is, but there's your maximum per dose. So 1 ml is typically your maximum. You're going to give those with your smaller gauge needles, your 25 to 27, and you're going to use that 3/8 of an inch. Okay, again, so short and small. Look on page 49 at figure 414 if you want to see this pretty much same one I had before. So give it a 45-degree angle, and you'll see the reasoning for us when we say pinch that skin up. So the reason we pinch that up is so that we deliver it where we want it to be. So we're pinching up that epidermis in the dermis so that we're actually getting into that subcutaneous tissue, okay? Do not aspirate this when you're giving heparin and insulin. There's no need to. It's going into that subcu tissue, so do not aspirate. Now, when we talk about documentation, you want to document where you gave it. Okay, did you give it in the right arm? Did you give it in the lower abdomen? Which quadrant did you give it in? Okay, and then of course, education. Well, if I'm a diabetic or I'm taking heparin for whatever reason, I don't want to continuously give that injection in the exact same site over and over and over again, okay? That's like pricking the same finger every single day to check your blood sugar. You don't want to do that, okay? You want to rotate those sites, okay? So whether it's insulin or heparin or whatever it is that you might be getting or educating your patient about, always make sure that you're reminding them to rotate those sites, okay? Again, go back and look in your book on page 49 at some of those available sites that you can use, okay? So documentation is important, where you gave it, how much you gave, and then educating your patient if you're discharging. Let's just say you're discharging a newly diagnosed diabetic patient. Well, they've never given injections, so you're going to use that teach back method, okay? So maybe at lunch, you take a blood sugar, you give them their sub-Q injection, and then at dinner or supper, whatever you want to call it, then you allow them to teach you how to give it so that you can assess their understanding of that. Okay, so remember, always making sure to rotate that side. That also goes along with patches. If your patient's wearing some type of, let's just say hormone patches, for instance, always make sure that they're rotating the sites on those also. Okay, so do not aspirate. You'll see why we use that 45-degree angle versus the 90-degree angle and why we're pinching that skin when we give those two injections. Okay, so be mindful of those. If you have any questions on any of those injections that we've talked about, how to give them, where to give them, how much to give, again, send me the email. So intramuscular injections, we give those in an area that has a rich blood supply. Okay, so it can create that rapid absorption. Now, it again does not create that instant effect that you will see when we're giving something IV, but it is still pretty rapid as far as absorption, okay, because of that rich blood supply. So again, the volumes for delivering medications IM are going to be 1 ml to 3 mLs. Okay, so remember, if you're giving more than 3 mLs of a medication, you are going to have to use 2 separate sites for injection. Personally, if I were given 4, I would divide it in 2 equal injections and deliver in two different locations. Okay. So for infants and children, they have that 1 ml per injection. Okay, so remember the limits on those. I assure you, you're going to see those again. Now, for a muscular injection, we're going deeper than just the dermis and that subcu tissue. So we're going to use usually a larger needle, a 20 or 22 gauge. And of course, it has to be longer, that 1 to 1.5. That's about average. But again, if you have a big, huge, muscular bodybuilder, then you may have to use a 2-inch needle to get to that deep inside their muscle. They have those big, giant arms, and so you may have to use a longer needle. So, of course, we're injecting at a 90-degree angle. We're going straight in. We are not going to aspirate. I know we used to always aspirate to make sure that we weren't in a blood vessel or anything like that. So now they recommend no aspiration for IM injections. Now, in order to give an IM injection, what do you need to know? Landmarks and your spacing. So if you look in your book on page 50, you're going to see the different sites for injection. Okay. Now with the deltoid, of course, that acromion process, you're going to find that acromion process. It's kind of hard to explain, but you almost feel a protrusive area right at the outer part of your shoulder. So then you're going to move down 2 finger spaces below. Okay. So that should help you avoid any other vessels or, getting right into the area of that acromion process. If you use 2 finger spaces below there, and then give your injection right there in the deltoid. Okay, so that's going to be for that one. Now your ventrogluteal, you're going to see that one also on page 50, figure 417. That's going to be, you're going to find your, I don't particularly like this because I feel like it's a very small space to find, but you're going to find that anterior superior iliac spine, okay, and you're just going to use a V shape with your fingers to give that. That's not my favorite, but just know that it is available, and you need to know the landmarks. You will see those landmarks again, I promise you. So know where those landmarks are and how to find them. Now, again, in children, you're going to use that Vastus Lateralis because that is the most formed or the most developed muscle in most of your children, and especially your neonates. Okay, so you're just gonna, it's basically dead center on the thigh. Okay, so look at that one on page 418. Now, of course, we want to talk about the perks of the deltoid. First of all, it's easily accessible. 9 times out of 10, and again, unless they're missing an arm, they have a deltoid, and it's just easy to access. So, boom, lift up the sleeve, you're there. Okay. A lot of those muscles, again, just going back when we're talking about those underdeveloped muscles, we just use that Vastus Lateralis, okay? And then sometimes you can use the deltoid, but again, you have to limit that to half an ml. Okay, so I always just go for the thigh. Use that Vastus Lateralis. So for IM injections, you're going to want to know the volumes, your needle gauges, the length, whether you aspirate or not, and your landmarks and the perks. Okay, know the difference between preferred areas for adults versus children. And if you have any questions, again, send me an email. This one, I just wanted you to see the difference between the Vastus Lateralis and how easier it would be to just pop that in and move on rather than trying to find that iliac spine on an infant, and how hard or how minimal effort it would take to just use the vastus lateralis versus finding that ventrogluteal site on a child, and how small that area really is for infants. Okay, so the vastus lateralis again is also easy to access. Now, the absorption is a little bit slower than the deltoid, but it's faster than the buttocks. Okay, so just understand that the vastus lateralis is one of the most developed. It's the easiest to access, and there's a smaller margin of error in hitting that site than the others. So this one is just a visual for you, making sure that you're avoiding those intragluteal injections. The dorsogluteal site is absolutely not recommended, and you can see why. There's a very small area where the nerves innervate that upper quadrant there. And so you can actually hit that area where that sciatic nerve is contained. And so that's why it's important to find your correct landmarks when you're using that ventrogluteal site. Okay, so I just wanted you to see why we want to make sure we're hitting those landmarks and how important it is, because we can damage those nerves when we're injecting in those quadrants. So it's very painful if we do so. Okay, so just be mindful. The dorsogluteal site is absolutely not recommended because of the damage that we can cause if we don't hit our landmarks. See, the ventrogluteal site, we talked about this a couple slides ago. It's used for children 7 and older if you choose to use that. You saw how small the area is on an infant if you're trying to find those landmarks. So typically used for adults. There are 2 videos attached here that kind of gives you a visual of finding those landmarks and administering those injections. So just take a few minutes and watch each of those videos. Again, it talks about your PPE and following your aseptic techniques also. And of course, assessing for allergies. Remember, you're inserting something that you cannot retract. Okay, so make sure you're always assessing for allergies when you're injecting medications or giving any type of medication for that matter. Okay, so Z-track injections. This is typically used with drugs that can stain or irritate tissues. So the first one that comes to mind is going to be iron. Okay, we all know iron can stain skin, teeth. So we want to try and avoid that. So when you're drawing your drug into your syringe, you're going to add a little bit of air into that syringe. And if you look on page 51, it's going to talk a little bit more about that. And I'll try and attach a little video so that you can see how to perform the Z-track method. It's not used a whole lot unless, again, you're using those injections that can stain or irritate the tissues. So you're going to want to pull that tissue down and away from your injection site. So you're going to inject the drug, you're going to release the tissue as you withdraw the needle. Okay, so it seals that drug inside the muscle. Okay, absolutely do not massage because we don't want to spread that around. Okay, so do not massage that muscle. LPN restrictions on IV medications. I, of course, made you do that first assignment in reading about your scope of practice. So you guys are familiar with most of these. If not, refer back to that exercise. So most of the time an LPN is going to assist the RN. So ultimately the RN is responsible. So in some states, an LPN may give IV drugs into an already existing IV line by piggyback. Okay, now we all know that LPNs do not initiate the actual IV system, but as you can see, you can piggyback. And so I did talk a little bit about piggybacking a medication previously in another slide. So the importance of paying attention to that piggyback is that I think I used the antibiotic as an example. It has to be at a higher level than your primary set, or it's not going to infuse correctly. Okay, so just be mindful of that when you're talking about piggyback method of dosing. Okay, again, refer back to that Nurse Practice Act and your scope of practice for what LPNs can and cannot do as far as IV medications. Now, when we're talking about piggybacking medications, you also want to consider whether or not they're compatible. Yes, there's a Y in that port, and so you want to make sure that you're not running into a situation where you need another line exclusively for a specific medication. I think I used rifampin previously also, because we don't want to create that precipitate that may occur when the two drugs mix. Okay, so always be mindful of checking that interaction as far as whether they can go through the same line or not. So let's talk about IV placement and IV fluids and the different types. So as far as IV types, you have peripheral, which is just inserted typically in your hand, your forearm, in those areas. Central lines are inserted, and the tip of that catheter is going to rest inside the superior vena cava of the heart. Okay, those are typically called your PICC lines. Ports are the same. Okay. So some of the things to consider when you're trying to decide on what is the best type of IV for my patient. Okay, so if you have a teeny tiny baby that is premature and you know they're going to be in the NICU for several months and they're getting medications very frequently, you're going to consider doing a central line, because if you've ever worked in the NICU or seen how teeny tiny their veins can be, they don't always have enough, I guess, veins available to continue putting in those peripheral IVs. And I mean, how painful and torturous is that for an infant to continue, sticking them when you can place a central line and continue to use that for medication administration? Okay, you stick them one time, you insert it, and typically they'll last for a very long time. They don't tend to migrate, or an infant's not going to be able to flop around with a PICC line and dislodge it typically. So just some things to consider also when you're selecting central lines versus peripheral lines or a port is, are they getting some type of medication that is irritating, or a vesicant? Now, a vesicant is something that might be necrotic to the tissues, okay, like TPN. TPN can be very necrotic if it were to escape outside that vein. And I think in one of the next slides, I have a picture just to let you see what can happen to I think it's a picture of an ankle, a foot of a neonate in which a peripheral line had infiltrated, and it was a TPN, which we call a vesicant. So anything that's irritating to the area, any type of drug infusion. So for those, you would typically see your patients with a port. So chemos are typically given or received through a port. Okay. We know those are typically under the skin. They're inserted there and then accessed each time they have to have infusions. Now, in order for us to infuse fluids through those lines, of course, we're always going to make sure that we have verified the order. And when we receive them from pharmacy, we're going to verify what we receive from the pharmacy against that order when we chart it or we scan it. We're going to make sure it's clearly labeled by the pharmacy. So when it's hanging, if Joint Commission came in and they want to see what it is, they want to compare it to your order, they can clearly read that label. So we're ensuring it's the correct type of fluid. Just because it's clear doesn't mean it's the same. Okay, you can have normal saline hanging. You can have several different medications. I can't think of a few right off, but anyway, just because it's clear doesn't mean it's the same type of fluid. Typically on those labels also, it's going to tell you at what rate it should be flowing, okay, your flow rate. So your order should also tell you how much to infuse, the duration, and the rate, okay. You don't typically have to calculate those yourself, but it's always very, I guess I would say beneficial. That's the word I'm looking for. It's always very beneficial for you to double check your fluid rates. I'm not saying that mistakes can be made, because we all know they can. We talked about the types of tubing. We've talked about macro drip and micro drips. Okay, so your macro drip, of course, is going to be a larger diameter, so you're going to be able to deliver that a little bit quicker than your micro drips. KVO, I don't know if many of you have been in facilities and are exposed to that, but KVO simply means keep vein open. So you may have an infant or even an adult that maybe they've sent a blood culture and they have a peripheral access or even a central line, and they're waiting on the results. So we don't want to lose that line. So we're going to keep some type of fluid flowing through that. It's usually only around maybe 1 or 2 mLs at a time. But anyway, we want to keep that vein open. That's what KVO means. So continuous IV infusions of D5W at 125 milliliters per hour. So that's typically how you would see an order written. Or if you're just giving a one-time dose, remember I talked about maybe your patient's dehydrated, or maybe we just need to get that blood pressure up if they're a neonate. So we're going to give a bolus of normal saline, and we're going to get 500 mLs, and they're going to give us a time frame, 30 minutes to an hour, whatever they decide. Okay, they're going to write your order. So that's some of the ways that you'll see those infusion orders written. Okay, either continuous or bolus. So IV complications or failure to infuse. A lot of times if you have IV solutions that are running and it's just not running appropriately, you're going to hear your IV pumps ding, 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 continuously reminding you that something is not quite right with your IV infusion. So check your tubing, make sure that your tubing is not kinked. A lot of times your patients may, if it's in the antecubital space, maybe they have their arm bent and that little tiny plastic is bent and it's not flowing. So just also check to make sure that's not the problem. All of our IV tubing has roller clamps, so make sure that they're open and flowing. A lot of times we'll close them off until we get that solution hooked up to our patient, and then we forget to unclamp the tubing, and so your IV pump is going to notify you typically. Now, if it's gravity, if it's flown by gravity, it's not going to tell you, it's not going to beep because there is no pump, okay? But if it's not flowing, then you may have to raise your pole, okay? If it's too low, it's not going to flow, okay? So remember that. Maybe your site is infiltrated. Now, infiltration, a lot of times you're going to see redness in the area depending on what you're getting. A lot of times if it's just maybe like normal saline or D5W, you're just going to start to see that it's going to feel cool typically if it's a solution of that nature. And you're going to see that puffiness around that site. You may even see some leakage. Okay, so it may be wet. So another issue could be that the bevel or the plastic catheter may be up against a wall, a vein wall, or a lot of times when you're starting an IV, you may bump up against a valve. So it just could be positional. You may have to just, move it and retape it a little bit. So just check for that positional instances where it may have stopped. You always want to check on your IV sites, especially if you're infusing something that is known to be necrotic or irritating to the tissues. Okay, check that site. I would check it every minimum of every hour. Okay, because later on in this, you're going to see what happens when you have an infiltration of something that can cause necrosis. Okay, if it's infiltrated and you're the LPN, you can't necessarily restart that IV. You notify your RN, your charge nurse, okay, immediately. And then, of course, if there are complications, you'll always want to document those. If you have to remove that IV, then you want to document what the site looks like when you do so. Okay, is it red? Is it enlarged? If it is infiltrated, what did you do for it? Did you put a warm compress on there? Okay, so always chart what you did once you discovered XYZ. Okay, just to cover yourself. So this is the picture that I've been talking about. This infant was actually receiving TPN, which is very, very necrotic to tissues if it is in fact infiltrated. So you can have, of course, most IVs are the plastic catheters. You don't really have needles, but when I'm talking about that, I'm just talking about dislodging that plastic catheter. So what happens is, babies move around and kick and things like that. So, and even adults, they're moving about and they've dislodged that catheter. So your fluids begin to infuse into the tissues. This is where you start to see that swelling and the redness, and it's very painful for when you experience an infiltration. Like I said, a lot of times it's going to be very cool to touch. You're going to see that edematous area. Now, in this picture, you can see that this has caused an actual burn to this patient, the TPN has. So it's very irritating to the tissues. So immediately, if you see that, you want to discontinue that IV. You stop the infusion. You're going to evaluate that tissue injury. Of course, with necrosis, you're always going to chart what you see. Chart exactly what you see. And this is why I can't stress to you enough about the importance of always checking on your patients if they have IV fluids going, because this infant could potentially lose that portion of his leg because of the necrosis if they can't get that stopped. Again, if you have that edema and that pain and swelling, you're going to want to put a warm compress on there, okay, just to help with that edema. If it's on a larger or an adult, I won't say a larger patient, but an older patient who's cognitive enough to, maybe keep that elevated and then apply a warm compress, that's going to help that edema, okay? So that picture alone should, make you want to check your patient's IV every 30 minutes. I know that's not possible when you're out on the floor, but at least educating your patient on, hey, if you feel pain, swelling, redness at the site and I haven't been back by, please call and let me know so I can come and assess that. Okay, so it's extremely important to assess your IV sites and documenting what did it look like the last time you checked it, because let's say you're there at 6:45 and you're giving report off to your oncoming nurse and she lifts up the cover or unwraps this infant and finds this. Okay, so you have charted that at 6:45 your skin was, your IV was intact, skin was pink, dry, and warm, no redness, no swelling at the site, blah, blah, blah. So she knows that probably, let's say she checked her patient at 7:30, 8 o'clock. She knows within that 30, 45-minute time frame, that's when her IV has been dislodged. Okay, so she's going to immediately discontinue those fluids. We don't want to continue infusing them in those tissues, okay? So then immediately report that, chart it, and notify the physician. So some other IV complications are going to be infection or phlebitis. Okay, so this is just an inflammation of the vein. Okay, usually occurs as either trauma. It can result from the insertion during an IV, or if you use an inappropriate size, or potentially from just prolonged use of that same site. Okay, if you can imagine, giving 10 different medications through that same vein, how irritating that can be. So phlebitis, again, is just that inflammation of the vein, and again, you'll want to assess for that. So how do we assess? Again, you're going to see that redness, swelling, and some warmth at the area, and it may even burn along that vein when you're injecting even just normal saline. They may say, oh, that really burns. So again, you may have to discontinue that IV and use a warm compress to alleviate that. So here we're going to start talking about some IV complications outside of infiltrations and those extravasations. In this one, we're going to talk about those allergic reactions to those IV medications. Now, I say medications, but we also have to remember that we also do blood transfusions intravenously. So not also blood, but we also do platelets and some other things like that. So immediately it's entering into that circulatory system. So if there is an allergy to whatever we're infusing, you're going to start seeing that pretty quickly. So you're going to see either signs of anaphylaxis if they're truly allergic and severely allergic to whatever it is that you're infusing. So you're going to start to see some hives and itching, some facial and maybe even their throat swelling. That's where we get into the issues where they're not able to breathe very well. Lightheadedness, maybe some vomiting. Okay. Most anaphylactic reactions recur within about an hour or so of taking that medication. But if there's a severe reaction, you may see it sooner than that. Okay. Now, with reactions to let's say a blood transfusion. When we do blood transfusions, we monitor that patient very closely for about the first hour. It's like every 15 minutes we're doing vital signs and checking on our patient. Excuse me. So we monitor them closely. Okay, if for some reason we suspect any type of allergic reaction, we immediately stop that transfusion or the infusion, and we notify our physician. Okay, so some of the things you might see with an allergic reaction is going to be chills, fainting, maybe some dizziness, and then fever. They may have some skin flushing. You're going to see them start to itch and maybe some shortness of breath. So those are all of the things that you need to monitor for when we're talking about allergic reactions. Okay, so just know that those complications can and do occur, and we need to monitor them closely. With blood transfusions, we monitor every 15 minutes for the first hour, and then we monitor them hourly until that blood transfusion has completed. So when we're talking about those reactions, make sure that you understand what you're looking for if you suspect some type of allergic reaction. Again, that's going to be either fever, chills, fainting and dizziness, maybe skin flushing, shortness of breath, itching. So those are going to be your cues to allergic reactions. Okay. Once we suspect a reaction or we start to see some type of symptoms of that reaction, again, you're going to immediately stop that infusion and then notify the physician. So some other IV complications we're going to talk about are going to be our circulatory problems. So we are infusing directly into the circulatory system. So what happens if we infuse too much of something for some reason? Let's just say, for instance, I'm supposed to be running my IV rate at 10 milliliters per hour. However, I accidentally programmed my infusion rate at 100 milliliters per hour. Now, working in a NICU previously, that would have been a massive error on my part by not checking it before I actually hit start. Because if you can imagine the volume difference that is for a neonatal patient weighing less than 5 pounds, that's huge. So always be mindful of checking your IV rates before you actually start them, okay? So this is what we would consider hypervolemia or just fluid overload. We just simply have too much sodium, water circulating in the body. So with that excess sodium, um, we begin to retain water. Remember, we have a salt-water balance, and our body works best when it's in the status called homeostasis, okay, where that everything is where it should be, and we don't have too much of any one particular thing. So we're able to function at our best in a homeostatic environment. So typically, hypervolemia is a result of another underlying condition or health problem. Like, okay, I don't know about you, but once in a while I do love ramen noodles. I think most of us do occasionally. And maybe I've had one too many. Well, we know that 90% of it is sodium. So I've had one too many. I have a huge amount of salt in my body. So I'm going to absorb or retain excess water to try and balance out that salt content in my body. Okay, so that's where my fluid retention is coming in. So that's not necessarily an underlying health condition, but I inflicted that problem myself by eating one too many packages of ramen noodles. Okay, now hypervolemia, of course, is treatable if we catch it early enough. We can prevent a lot of those issues or problems that occur with hypervolemia. Now, let's talk about a few of the underlying conditions that I mentioned previously. Maybe your patient has congestive heart failure. Okay, that's just simply when your heart cannot pump enough blood to meet your body's needs. Okay, so if our heart's not pumping appropriately, then our kidneys are probably not working correctly either. So then that also leads to an excess amount of fluid in our body. So we're retaining that bodily fluid. So a couple other things that can cause hypervolemia is going to be cirrhosis of the liver, some type of kidney failure. And again, I briefly mentioned hormones. Of course, you know, we all sort of retain that water when our hormone levels are up and down. So, and then of course, IV fluids. Our IV fluids, most of you, if you've never worked in a hospital setting, most IV fluids that we're infusing contain some type of sodium chloride, um, and water, you know, sterile water of some sort, to replenish body fluids. So let's say you have a patient who's dehydrated. 9 times out of 10, they're going to get some type of fluid that contains salt and water to balance those out. Okay, there's various different ones that they can infuse. So just be mindful of the salt content. So what we're talking about is just simply a circulatory overload problem with having too much of something circulating that shouldn't be. Okay, so some of the hypervolemic symptoms can vary depending on where the fluid is collecting. Okay, so a lot of times people who may have some type of liver cancer, you'll see them with the extremely large abdomen. And if you press on it, it's almost board-like, okay? And that's where you're going to see that ascites. That's what we call it, where that fluid is collected. And now, many times, when there's too much, a physician will go in and do a thoracentesis, where they go in and they remove that fluid from the abdomen so that that patient is, number one, not carrying around that excess fluid, and they're able to breathe a little bit better. Okay. So now as you begin to assess your patients in the beginning, some of the first signs of fluid overload, of course, you're going to see some edema. You're going to see edema in the face, in the feet and the wrists and ankles. Okay, now some of your patients may complain of cramping, headaches, stomach bloating. Of course, many times, if it's an extreme case, that relates back to that liver cancer, that diagnosis. Now, with pulmonary edema, you can imagine we have all this excess fluid in our lungs and how difficult it is sometimes to breathe with pneumonia. Think of your pneumonia patients with all the excess fluid in there. So you're going to start to see your patients become tachypnic. They're going to have some dyspnea and shortness of breath. So also think about when we're talking about this pulmonary edema in your assessment, what kind of lung sounds are you going to hear when you're auscultating this patient with fluid overload? Think about those different sounds. So typically it's going to be crackles. Anytime you have any type of fluid in your lungs, you're going to hear those crackles. Typically with fluid overload, you're going to hear it in the lower lobes. Okay, so just think about your assessment when you're talking about your fluid overload. So this is why it's extremely important for us as nurses to assess our patients on hourly or every couple hours on that basis. Not just going in to give medications and then, heading back to the nurse's station until a call light comes on. If you're infusing some type of fluid, again, we want to make sure that we're checking the rate, but we're human, anyone can make a mistake. But if you go back quickly enough and recognize some of those symptoms, then you may be able to quickly stop that issue. Now, when we talk about fluid overload, you have to also be mindful that our brain and everything is not exempt from that. It's not excluded. So as they become saturated, think about our electrical impulses and how it affects that. So it's easier to transmit our signals when we're in that homeostatic environment. Okay, so if we're overly saturated, we have too much fluid, then those impulses are not traveling as well as they should be. So this is where you're going to start to see some of those CNS effects, okay? Some nausea, vomiting. Your patient might be confused. They may be lethargic or restless. So when you're studying about the fluid overload, don't just know what fluid overload is, okay? I say this all the time, but I want you to understand that it's not just about knowing what fluid overload is by definition, but being able to assess your patient and gather that data that will lead you to a diagnosis of, oh, fluid overload. That's what I suspect my patient has, okay? So with all of that assessment data that we talked about, the crackles, the restlessness, may even see some weight gain if it's not caught quickly. You're going to see that patient, they're not going to be the pink and dry, they're going to be probably pale, um, maybe even a little gray or blue. It kind of just depends on how overloaded they are. So if you suspect that, I would immediately stop my fluids and report that to the physician. Okay, so it's really important to continue monitoring that. So also think about fluid overload in the sense that if you have all that excess fluid, how much extra work your heart has to do to circulate all of that. So we can really cause some damage with fluid overload in our patients. So always be mindful of assessing your patient, know what to look for, and when you discover something that has led you to this particular nursing diagnosis of fluid overload, stop the infusion, report it to a physician. Okay, guys, let's talk about percutaneous drugs. So they're just simply drugs that are applied to the outer layer of the skin and absorbed through the epidermis, the dermis, and eventually into the blood capillaries and into the bloodstream. So as we talk about this, we have to, of course, consider the hydration status of the skin. Okay, so the better the hydration, of course, the better the absorption. So if you have a patient who's severely dehydrated, it's probably not the best method for delivering medications, depending on the situation, of course. You always have to consider that. You need to consider the age of your client. You know, are you dealing with an older patient who has extremely thin skin? Or a pediatric patient who has that really soft skin and it would absorb easier. What about farmers? Just I use farmers or construction workers who are always out in the sun a lot and they have that really tan, thick skin. Sometimes it's hard to penetrate that. If you've ever tried to start an IV on one of these little farmers who has, you know, been farming for 50 years, you'll understand what I mean with that really tough, thick skin. So you have to consider those things. Let's see, what else? Oh, of course, the length of time that the drug has contact with the skin. You know, if you're putting a drug on, you know, your arm or the back of your hand or even your face, you know, how many times a day do you wash your face or how many times a day do you wash your hands? Things like that you have to consider. Also, you have to consider when you apply that medication, your body temperature. Are you sweating and the drug is not absorbing? Okay, you're just sweating it away. Okay, so those are just some of the things that you need to consider. Abrasions and open wounds. We do not ever want to apply any kind of medications to open wounds, okay, or abrasions really. I know a lot of times we use Neosporin on little cuts and scratches. But for those deep open wounds, we don't ever want to use those percutaneous medications. So, a couple of medications that come to mind when we're talking about percutaneous, first of all, are your hormone replacement therapy patches, okay, or even birth control patches. You just pop them on and it absorbs at a specific rate through the skin and does what it's supposed to do. It provides a specific amount of, you know, hormone or whatever to prevent either hot flashes if it's for menopause and hormone replacement, or hopefully preventing pregnancy if that's what your intent is for birth control patches. Now, when we talk about those specific medications that we use on the skin, when we're talking about patches, of course, you always want to make sure that you're, again, educating your patient on rotating the sites. Okay, we don't always want to continuously put that same patch in the exact same, you know, spot. So make sure you're telling them to alter their locations. Now, another drug that is used a lot, especially in the ER, is going to be nitroglycerin. So that's a medication we want to deliver quickly, and we can either do it sublingual, so it's immediately, you know, into the bloodstream if we deliver that by mucous membranes. Okay, so we're going to give them a little tablet, we're going to let it melt away under the tongue, or we're going to use, it's a gel, but it's almost like a toothpaste type medication, and they're going to put it on a little tiny, if I can, I'll add a picture so you can see what I'm talking about. It's a little measuring tab. It's just a little thin piece of paper, and they'll put X amount of nitroglycerin paste on there, and they'll apply it to a patient's chest typically. Okay, it's kind of thin skin there, so it's quickly absorbed, and of course we want that to go straight into the circulatory system, and hopefully preventing any further issues with our heart. So one thing that I absolutely positively want you to be mindful of is when you are using any type of medication that's, you know, those percutaneous medications that are going on the skin or under the tongue, anything like that, always be mindful of wearing your gloves. There is nothing worse, and you'll do it one time and you'll never do it again. But if you ever come in contact with nitroglycerin on yourself when you're applying it to another patient, you are going to end up with the worst headache of your life, okay? Because what happens is that nitroglycerin gets on you, it's going to dilate every single, you know, vessel that you have, so you're going to end up with a massive headache. So be mindful of always wearing your gloves when you're dealing with nitroglycerin, okay? And again, I will put a picture in the next slide so you can see that measuring device for that nitroglycerin and some of the other medications also. There are some steroids that will also use this little measuring tape. It's really just a piece of paper, basically. It has measurements, and you'll put it on there by centimeters, or they'll tell you how many centimeters of whatever the medication is to apply to that paper, and you'll just put it on their skin. Okay, so if you have any questions about the percutaneous medications, then again, please let me know. But all of those factors you need to consider when delivering your drugs in that manner. So this is the nitroglycerin ointment or paste, whatever you want to refer to. It looks like a paste to me. So this is going to be your applicator paper that you'll see often in the ER. Now sometimes they have single doses of nitrobid, and it comes in like a little foil package. So you'll just, however many inches or centimeters your order is for, you're going to just put that on the paper, and you'll see they've applied it directly to this person's chest against the skin with their gloves on. So remember, always wear your gloves with nitroglycerin ointments. I promise you won't do it but one time if you don't. So continuing on with the percutaneous routes, of course we have our ear medications and our eye drops, and we've talked about those. Our nasal sprays, it says nasal drops, but any type of spray that you would use, or hydration drops for your nose. Our mouth, of course, is going to be our mucous membranes. We're going to do either some sublingual or buccal melts typically, or a gel. You have that glucose gel that we talked about before, some mouthwashes, and of course, I'm sure at one point in time we've all bitten our tongue or our jaw, and we've had those little ulcerations. And so when I talk about topicals, I'm talking about topicals that you would put inside the mouth to heal those ulcers. Some vaginal creams, again, we have skin there, so you may have some type of skin or cream that you would put in that area. Some other topical creams and ointments and powders that come to mind are going to be creams for maybe some type of fungus. If you have ringworm or something of that nature, and you're going to use a topical cream or ointment. Powders, I think of yeast infections or athlete's foot. You're going to use some type of powder or maybe a lotion on those. And then transdermal patches, we talked about hormone replacements, we talked about birth control. One thing we didn't talk about as far as transdermal patches, again, are sometimes we have pain patches. A lot of our patients use those, and you have to be very careful about disposal of those. I was once told a story about a father who was waiting for his infant to be born. He was, of course, a known addict and had fished out of one of the biohazard boxes a transdermal fentanyl patch. Okay, so you just have to be mindful of disposal of any type of medication. People who are desperate will do desperate things. Okay, so just know that transdermal can be several different types of patches. And again, I want to mention to you, when you're talking about transdermal patches and the application, you also want to make sure to educate your patient about placing them and rotating those sites. Okay. One of the big things is when, of course, at home, your patient's not really going to use gloves to apply those patches. But just be really careful about, especially pain medication patches, keeping them out of the reach of children. And when you're applying those or taking them off, don't leave them out so that another person may have to throw those away, because we don't want them with that medication on their skin, because it does absorb. So any questions about percutaneous routes or the medications used, again, just email me. Moving on, again, we're just talking about some transdermal patches. We're going to hopefully apply them directly to an area of clean skin. Again, you do have creams, ointments, lotions, and your transdermal patches. So the medication basically has a slow release, especially I know with hormone replacements, you may have to change them twice a week. It just varies, okay? But there's just that slow release of medication to maintain that optimal drug level for the duration of that patch, particularly. Again, it may be a weekly patch, or you may have to change them bi-weekly. And again, rotating that site. So also when we talk about the site, we also want to make sure that we're avoiding lesions, okay? Any type of breakouts, we don't want to put those patches there. We want to avoid tattoos, of course. You know, we have a lot of scar tissue typically around an area of tattoo. So it's a little bit harder for medications to absorb through that if it's going through the skin and then there's lots of scar tissue there. We want to avoid those areas, and especially broken skin, okay? Broken skin is kind of like putting alcohol on a wound, okay? We don't want to do that. Of course, we always want to make sure, I talked about fentanyl patches previously, we want to make sure that we're removing the previous patch before we put a new patch on. And we absolutely 100% of the time should educate our patient about the fact that even though it's a patch and you don't really think about overdosing as much with patches, it can happen, especially with really any type of patch, but hormone replacement therapy, of course, and pain patches are number one in my mind. So if I'm wearing 2 fentanyl patches, I'm getting a double dose and I might not be alive tomorrow. Okay, so always be mindful of educating them about removing one before you apply another. And again, always wearing those gloves for protection against contact with any type of drug administration necessarily or specifically to the skin. So always be mindful of your protection. Again, that is just as much for your protection as it is theirs, okay? So choose your sites carefully. Make sure that you know from this slide what areas to avoid and why. And then most importantly, removing the old patch before applying a new one, okay? So any questions on those, again, just let me know. Okay, so let's talk about some eye drops and ointments. So as we talk about the administration of these, we probably will see numerous patients, especially our older populations, who suffer from various conditions such as glaucoma, dry eye, or some type of infection maybe, pink eye, something like that, or even just allergies, and we use, you know, some type of drop for that. So with those conditions, our patients could potentially be taking 1 to 3 drops. Okay, so we as nurses need to educate them on how to do it appropriately, first of all, so that they actually receive the drops and they're not continuously wasting those drops and increasing their cost because they're having to purchase more and more. Some of you may go forth and work in a surgery center where they do cataract surgeries or any other type of eye surgery. And so you're going to be instilling lots and lots of eye drops. So we want to make sure that we're not doing any type of cross-contamination with our patients. So that is one of the, I guess, one of the most important things with the administration of eye drops and ointment is making sure that we're not cross-contaminating. Some of those drops can be multi-use and multi-patient use. So you want to make sure that we're not cross-contaminating anything. So if your patient were to be wearing contacts, you want to make sure that you ask them to remove those contacts. It doesn't do any good to put drops in there if they're wearing contacts. Of course, we've washed our hands and we're wearing gloves, okay? And so what you're going to do is just pull, you're going to ask your patient to look upward, okay? Just tilt their head up a little bit. You're going to then take the lower lid and pull it down just ever so slightly to create a little cup, okay? And so then you're just going to instill that drop of eye drop in that little cup or goodness gracious, conjunctival sac. I couldn't think of the word. There we go. So in that conjunctival sac, which we normally call just a little cup, okay, that way it gets directly into the eye, and then you just have them close their eye for just a moment. Do not let them immediately put a Kleenex on their eye once you put that medication in there, because it just sucks it right back out, okay? They can dab any drips that may leak out the sides, and that's okay, but ask them to not put it directly on the eye and do not rub, okay? We as nurses have to ensure that we do not touch the dropper, any part of the bottle, the tip of it, to any portion of that patient's eye, okay? Whether it be eyelashes, you know, eyebrow, whatever. We don't want to touch their eye in any way. Same thing with if you have ointments, okay? We don't want to do that. If you drop it, get a new one, toss it. We do not want to induce an eye infection, okay? We don't want to cross-contaminate. So infants, when they're born, they actually receive erythromycin, a little ribbon of erythromycin. And so we do the same kind of thing. Basically, we pull that down a little bit where we don't actually insert in the cup. We just kind of, just a little tiny bit in that lower lid. So you can form that cup to put that ointment in there, and then you just have them close to distribute that evenly. Of course, it's going to cause some blurred vision, and that's okay. As that medication begins to absorb and dissipate, then they're going to be able to see more clearly. Okay, so you might want to forewarn them if you're using an ointment. Many times after cataract surgeries and deliveries, they always use that erythromycin, and that's just in the prevention of any type of infection. Okay, so any questions on those, again, send me an email. We'll discuss it a little more in depth. But again, make sure you're wearing your gloves to protect your patient and changing those in between. So when we talk about administration of ear drops for our patients, many times we do this in the summer because of swimmer's ear or ear infections even. So think about how you're going to administer those to children. Of course, we want the affected side up. Well, children or adults, we want the affected side up. Now, for infants, they're different. And the easiest way to remember that is they're small and they're usually down below adults. So when they're standing, so you're going to pull down and back for infants and small children so that you get a straight pathway through the ear canal. Okay, for older children and adults, remember when they're standing, they're taller than children, so you're going to pull up and back for older children and adults. Again, that's just straightening that ear canal to give you a pathway to the ear canal. So we don't want to instill cold drops. That's just rude. But so we try and warm them to body temperature. Just, I don't know, if you have a blanket warmer, just put it inside a blanket for just a couple seconds, or just kind of gently rub it between your hands to warm those up just a little bit. Remember, we always want to wear our gloves. We don't want to touch the dropper to the ear. Okay, so we want to just hold up and back or down and back. And squeeze that into the ear. Now, we want them to keep that affected side up for about 5 minutes, because that's how long it's going to take to drain into that ear. Okay, that way when they're standing up, it doesn't just leak back out. You can put a little small cotton ball in the ear. Just make sure that with children, they don't just take it out and, stick it up their nose or whatever kids do. So just know how to administer eardrops to infants, which way you pull the ear, and to adults, how to pull the ear, and how long it takes to actually drain into the ear. So for inhaled drugs, most of these are going to be for respiratory issues. So you have some metered dose inhalers, and they're pressurized. Typically, this is going to be your asthma patients who have the little rescue inhalers that you see them carry around. Okay, so those are going to be your metered doses. So they're going to, squeeze that, and it's going to deliver one single dose to them. Okay, so that's your little pressurized inhalers. And typically, again, those are your rescue inhalers for your asthma patients. Some inhalers are just dry powder. Okay, so it's basically just delivered. You squeeze it, and your patient takes a deep breath, and it's delivered. Okay. Now, for both of them, you want to make sure that you know how to educate your patient, especially if you're sending them home with them. They're not going to have a respiratory therapist at their side. So they're going to take 3 deep breaths, exhale, then they're going to inhale as that device is activated. Now, once they inhale, we want to ask them to hold that for as long as possible, so that they're not exhaling anything that might be left in there. Okay, so just kind of ask them to hold it for as long as possible. Okay, we want to get the maximum effect of those two. Aerosols, this is sometimes for patients who may have had like a severe asthma attack, or some type of pneumonia, or they just need a breathing treatment. You'll hear them talk about breathing treatments in the hospital. And this is where it's a continuous spray or a mist of medication that's basically mixed with a flow of oxygen. Okay, it's typically used with like I don't want to say a non-rebreather mask, but that's kind of what it looks like. There's just those oxygen masks. Okay, that's typically the aerosols that I see. So be mindful of a couple of things with inhaled drugs. Number one, you want to make sure that if they're supposed to use a spacer, some of them come with a spacer, they need to make sure they're cleaning those spacers, and they need to clean their inhalers. If they use an inhaler on a daily basis, make sure they're taking, an alcohol wipe or something and cleaning that off. Okay, so we don't have all those germs left on there, because what happens is if we use it and use it and use it and we don't ever clean it, then we're going to end up with some type of infection in our mouth. I'm sure many of you have heard of thrush. Okay, it's not comfortable. A lot of infants would have thrush in the NICU, and so it became very painful. They weren't even able to eat many times. So we want to avoid those infectious potentials. So educate them on cleaning them, educate them on proper use of them. Okay, so if you have any questions about inhaled drugs, let me know. We'll talk a little bit more about that. So I talked a little bit about vaginal drugs earlier. So some of the different types of drugs are going to be your creams, your jellies, sometimes tablets. I've never really seen a tablet vaginal drug myself, but I'm sure that if it's in your book, they have it available. foam, and then suppositories. Okay, a lot of times this is going to be for yeast infections, or sometimes some hormone replacement therapies are also creams that are inserted. So you want them at room temperature, of course. And then, as I said previously, ATI says that when you're inserting the medication, you have to insert it so that it contacts the posterior wall of the vagina. Okay. And remember, I said if you're inserting a medication and you have whatever you're inserting it with, you want to make sure that you're cleaning that in between each use. Okay. Most of the time, if you have an applicator with your creams or foams or whatever, and you're using it at home, it's going to be a multi-use. Okay, you're going to use it over and over. So make sure you're also educating your patients on the fact that when you dose, make sure you clean it with soap and water after each use. Okay, now when we insert those medications, we don't want to immediately stand up. And remember, I talked about them being in a lithotomy position. I'll try and post a picture here so you, I'm sure most of you who are female already know what I'm talking about. But so have them remain in that position or on their side for about 10 to 15 minutes so that that medication can melt and absorb. Okay, if you're just inserting it and you stand up immediately, it's just going to come right back out. Okay, so we don't want to waste that medication. So again, education is important. Okay, educating them on cleanliness of their applicators, where it must touch or where it must be inserted, and then how long they must remain in a certain position to ensure correct absorption. Okay, so again, education is key. Again, this is just kind of a review from a previous slide early in this lecture. So rectal drugs is, again, a preferred method when there's persistent nausea that has not been responsive to treatment, and vomiting, very persistent nausea and vomiting. Of course, we all understand that with nausea and vomiting, if you continue to vomit, you're not absorbing anything. So therefore, we're wasting our resources by giving it to you orally. Okay, so I always use Tylenol as an example, simply because we use that a lot in the NICU and in pediatrics for fever or for pain. Okay, because we can just pop that in, and we don't have to worry about the absorption of that, unless, of course, you don't get it in the correct position, or the correct placement, I should say. So we talked about putting them in the correct position, which is the Sims position or left sideline. Always use a water-soluble lubricant. Okay, we don't want to use Vaseline to insert suppositories. Okay, so something water-soluble. Now, I did talk to you before about inserting this drug past that internal sphincter. Okay, you have to get it past there, because I can't tell you the number of times that I've tried inserting in a baby, inserting a suppository, and before I even get the diaper back up, I see the suppository in the diaper. They immediately pucker when you start to insert anything. I can't blame them. We probably all do. So you want to get it past that internal sphincter, and for adults or whomever, you want to make sure that they remain in those positions for about 5 minutes, again, for absorption. Now, for infants and children, you may have to what we call squeeze baby cheeks. Okay, you're going to squeeze those little butt cheeks together to make sure that it absorbs and they don't just immediately pass it back out. Okay, so preferred positions, make sure that you know what position you're going to, or the best position for inserting. Know why we give rectal drugs versus oral or anything else. And then, of course, making sure you use your gloves and you always use a lubricant. And then, of course, remember how long you want your patients to stay in that position for absorption, okay? And how far you want that rectal drug to go in order to not have them just shoot that back out.